अच्छी अच्छी बातें बता सकते हो सुबह सुबह। अरे आवाज नहीं आ रही है।
अनम्यूट करो सर।
Today we'll be discussing a very
अरे नहीं, वेबिनार के बारे में मत बोलो।
नहीं मैं तेरे से बात कर रहा हूँ। Today we are discussing a very intricate topic, pancreatitis. मतलब जैसा बोलते हैं ना, किसी के मुंह में एक और पेट में एक अलग रहता है, वैसा वो pancreatitis का वैसा issue है. Pancreatic malignancy is very difficult to really judge because the symptoms may not present the way always like a book picture. So that is why, and the concept that pancreatitis can present like a pancreatitis, but it can ultimately turn out to be a malignancy. And pancreatic malignancy is something very bad. We have lost one of our friends with that.
अच्छा.
Then our Goa minister also. So it's a very bad disease. It's very difficult to treat even in advanced science of today. So that's why it's a very important CME we are supposed to be attentive to in true sense.
I think
so Dr. Award, now it is 261.
Yes, start. Yes, sir.
Yeah, President, sir.
We lost Dr. Dhairyashil Sawant, I think we lost in pancreas.
Correct. Yes.
Yes, we can start.
Good morning, friends. I welcome you on behalf of Indian Medical Association Mumbai branch and CGB sub-faculty. I am a CGB sub-faculty. Today we have got the CME on pancreatic disorders. It is a courtesy of Sir H.N. Reliance Foundation Hospital and Research Center. We have got all the oncosurgeon and the radiologists. They will update us with the latest treatment and case-based discussion. Before we start the program, we have got another CME on the next Sunday, 6th of February. So people can make a note on this and take the MMC credit point. Now I'll hand over the mic to our president, Dr. Jitesh Mehta.
Hello everybody, good morning to all and a very warm welcome on behalf of IMM Mumbai branch. Friends, this is the month of end of January, and the next month, February, is the time to collect all your credit points for MMC renewal of your registration. By the end of February, you shall be, whatever points you have to collect by the end of February. So that is why IMA is trying its best to give maximum webinar CMEs with credit points, and I'm sure people will take advantage of it. So today being 30th of January, the day when we remember Dr. Mahatma Gandhi, Bapuji, our father of the nation, who was unfortunately assassinated on this day. And world over, he has been, you can see, was a legend in his time, and the coming years also he will be remembered, and he will be the inspiration to many of us and many of our great leaders. Narendra Modi ji is one of them. So in remembrance of Mahatma Gandhi ji, we move forward, and I will request Dr. Usha Shah to come again on the screen and take this further.
Thank you, President Dr. Jitesh Mehta. Now we'll start the program. The first speaker is Dr. Somil Vyas. He is a oncosurgeon, gastrohepatobiliary surgeon, and transplant surgeon. I request our President-elect Dr. Anil Awad to introduce the speaker. Over to Dr. Anil Awad.
Thank you, Dr. Usha Shah. I'll just share the screen to display his biodata. Yeah. Good morning, all. Dr. Somil Vyas is a consultant in hepatobiliary and pancreatic surgery, surgical oncology, surgical gastroenterology, and liver transplantation at Sir H.N. Reliance Foundation Hospital and Research Center. He did his MBBS and MS in General Surgery from St. G.S. Medical College and KM Hospital, Mumbai. He later moved on to the Tata Memorial Hospital and Cancer Research Institute, wherein he received comprehensive surgical training in all aspects of cancer surgery. After a brief tenure as assistant surgeon in Division of Surgical Oncology at the Bombay Hospital, he moved on to UK, wherein he received comprehensive training in all aspects of liver, biliary, and pancreatic surgery and upper gastrointestinal surgery at the University College Hospital and Royal London Hospital, Barts, and the London NHS Trust and Royal Free Hospital Medical School, London. He received FRCS in HPB and FRCS in Upper GI and HPB from the Intercollegiate Specialty Board, Royal College of Surgeons, UK. He has also passed the advanced examination of the European Board of Surgery, leading to the award of the Fellow of the European Board of Surgery, HPB, namely FEBS. He has been instrumental in setting up the departments of liver transplantation, gastrointestinal surgery and oncology, hepatobiliary and pancreatic surgery at the Sir H.N. Reliance Foundation Hospital and Research Center. Today, Dr. Saumil will talk to us on pancreatitis, current clinical perspective, and again, he'll come back to talk on another topic, that is the pancreatic malignancy, principles of the management. I hand over the mic to Dr. Saumil Vyas.
Thank you, Dr. Awad. Good morning to everybody. Good morning to Dr. Mehta, Dr. Usha Shah, and all the office bearers of the Indian Medical Association. Good morning to my co-panelists. They are very eminent radiologists from the HN Hospital, and to all the delegates and attendees attending on this Sunday morning. I'll just start my screen sharing and just I'll wait for your approval that you can actually see my slides. Just let me know.
Yes, sir.
Is the slideshow visible? Is the
Yes,
slides
sir. Yes,
visible?
sir. Yeah.
Okay, fine. Okay, so I'll just get on to the slideshow from. Okay, so is my first slide visible to you? My name and things?
Yes, sir. Yes.
Okay.
You can go ahead.
Okay.
Yeah.
Thank you so much. So it's a pleasure to be here this Sunday morning, and we'll go through some basics and some intermediates as well as the advanced aspects of managing this very difficult condition, which by its own nature has a inbuilt morbidity attached to it. And it's a very good initiative by the Indian Medical Association that we have combined a clinician and radiologists, because without radiologists to manage this is extremely difficult, as is the case with pancreatic cancer. And you do need a team of dedicated radiologists with a special interest in pancreatic imaging to help with a very effective multidisciplinary management of this condition. So as was announced, we're from the Reliance Foundation Hospital, a state-of-the-art center in South Bombay with exquisite infrastructure and facilities. And the surgical oncology is one of the thrust areas that this hospital offers. So I would basically look at the talk, specifically looking at acute pancreatitis, chronic pancreatitis, looking at the complications of acute and chronic pancreatitis, and looking at principally how do you manage and where do you intervene, where do you do conservative management, surgery, intervention, etc. So let's go through acute pancreatitis first. I think there has been a rising incidence world over. The incidence keeps on increasing fundamentally because it is fueled, because we are diagnosing it more, and also because there is an increased intake of alcohol. The mortality has remained more or less stable since the 1970s. That is, when you look at severe pancreatitis, we brought it down to about 20%, but it's still a significant 20%. And the severity is largely based on a large number of clinical scoring mechanisms, including imaging and blood tests. But they still have a poor accuracy. When I'll come to the data a little later, but when you rely on exclusively on clinical criteria and couple it with imaging, the accuracy goes up higher. But when you just depend on a single modality, you're definitely going to fall short of predicting the correct severity. There are, biochemically, there is an inappropriate enzyme release, which leads to an inadvertent stimulation of the pancreas. There is a digestion of the gland, digestion of the surrounding structures, complicated by infection, which essentially will lead to either a systemic inflammatory response syndrome or organ failure. And subsequently, it gets complicated by an addition of infection in the background of an underlying necrosis. and a few cases can become chronic. So how do you really diagnose? I think this is the basic. Patient comes into the outpatients or into the emergency with acute abdominal pain. And so that is the fundamental characteristic. I think we all know that there is a severe acute abdominal pain radiating to the back associated with variable degrees of nausea and vomiting. And this can have a variable history of a few hours to a few days. You carry out a set of blood tests, but typically you would depend on an elevated amylase or lipase for the biochemical diagnosis. And then you would have an imaging to confirm and look at the pancreas structure and to confirm whether there is pancreatitis or not. Specifically, I would like to mention at this point that you need at least a minimum 3 times elevation of the amylase or lipase above the upper limit of normal to biochemically diagnose what we call as a hyperamylesemic state or pancreatitis. Just having a mild elevation necessarily could be misleading. We see it very often in non-specific abdominal pain, or sometimes when you have acute cholecystitis or appendicitis, you could have a marginal elevation. And therefore, all international guidelines now say that you should have it raised 3 times above upper limit of normal. There are a few guidelines which go on to say at least 5 times upper limit of normal. And when it comes to choosing between amylase or lipase, lipase is more reliable because it is an enzyme which is specifically secreted by the pancreas. Amylase can have false elevations from other causes, but lipase has a higher half-life. It stays in the blood for a longer period of time, and it is secreted by the pancreas. And therefore, lipase is possibly, if it comes to choosing between the two, lipase is first among equals. And then, of course, there is a role for imaging. We would come to that through the talk, whether you need to do an ultrasound, CT, MR, what should be done at what point. Why does it happen? Almost 1 in 2 cases, 50% is going to be because of an underlying gallstone. Either you have an obvious stones or you have microlithiasis. So even if you can't document a stone, in at least 80% of patients, you will have a small sludge or stone, which is the responsible offender. 25% of the patients would have alcohol as the etiology, and the remaining 25%, we don't really know why it happens. And in any large series, you would expect that up to 20 to 30% of patients, you will not be able to identify a cause, and we label it as idiopathic. Now, are they truly idiopathic? Not really, because when you actually try to bring down the causes, you can attribute it to some kind of a virus, or you can have some medications, or there may be calcium abnormalities, lipid abnormalities, but these conditions are difficult to diagnose when the patient comes into the casualty with an acute abdomen, and therefore you say they are idiopathic. But when you truly dissect of the idiopathic reasons, you can actually bring down this percentage from 20% to about 10%. How does a typical acute pancreatitis behave? Well, clinically, you could have either a mild episode or a severe episode. It's as simple as that. Mild meaning it comes, it goes, it may come back again, depending on the etiology. And severe is, of course, that it will linger on for a long time and be a significant cause of a prolonged hospitalization or recurrent hospital admissions. And it may contribute substantially to economics of the patient, as well as the length of stay in hospital. So again, as I said, really, truly miscellaneous causes are 10% and truly idiopathic are 10%, because as we have learned more and more about the genetics, the proportion of truly idiopathic pancreatitis has actually come down. So I think one of the simplest things that one can do bedside is to differentiate between gallstones and alcohol. I think history is, of course, important. But the most important characteristic is that when you find elevated transaminases, an ALT or an AST, which goes to more than 150 or more than 200 within 48 hours of onset of symptoms, it is a typical situation of biliary pancreatitis. So elevated transaminases and transaminitis correctly predicts gallstones in 85% of the patients. So even in these situations, if you can't document a stone, but if you have this biochemical abnormality at the index presentation, it is reasonable to conclude that, yes, this is biliary pancreatitis. You very often have a stone which has just transited the bile duct and has gone past into the small intestine and can't really see it on any of the imaging modalities. Doing an endoscopic ultrasound EUS would be the ideal thing, but again, it's an invasive procedure, not universally available, user dependent, and therefore it is not really advocated. because you have an 85% sensitivity of biochemical marker. So what will happen to most acute pancreatitis? Almost 80% of them are going to have a mild attack. They'll come and they will resolve over a period of time. They have a few days in hospital and the patients go away after good pain relief and hydration. And 20% of these patients will go on to develop complications. So we typically have had the Atlanta guidelines, which have guided clinical management. These were first devised in 1996 when the initial terminology was brought out, and subsequently it has had various revisions, and the latest revision happened in 2012, and then we had an update in 2016. But what the Atlanta classification principally does is that it divides pancreatitis to understand its complications. And it says that there is an early phase, 1 to 2 weeks, and a delayed phase beyond 2 weeks. And therefore, if you are in an mild acute pancreatitis, which now radiologically we define it as edematous interstitial pancreatitis. Dr. Karthik and Dr. Swarup would elaborate on that. But that's essentially a phase which comes and goes. There is edema in the pancreas, the edema settles down, and as it settles down, the patient clinically improves and is discharged in 2 weeks' time. And as we said that sometimes there can be a severe attack of pancreatitis, what we call as necrotizing pancreatitis, where the pancreas loses its blood supply, gets necrosed, and very often the inflammation spreads beyond the pancreas into the peripancreatic tissues, the surrounding colon, etc. And that's the group that really is going to have a guarded prognosis. So 2 weeks has been an arbitrary cutoff point. And these attacks could be classified as either mild, moderately severe, or severe. Now, how do we classify the severity? One looks at various things. One looks at the element of organ failure. Is there any coexisting organ failure which is there? We principally look at the cardiovascular system and the renal system. Are there any local complications? Are there any systemic complications? And is there a mortality? And it's very clear that when you look at mild and moderate, as I mentioned, the attack comes and goes. The moderate episodes may have an element of local and severe complications, but the risk of mortality is less than 10%. But when an episode of pancreatitis exists or extends beyond 2 days, there is hemodynamic compromise to the point that the patient needs an ICU admission. They start requiring inotropes. There is a drop of urine output. The creatinine increases. And in the background of medical comorbidities, this becomes even a more difficult situation for the patient. So if you have more than one system involved, it is called multiple organ failure. And associated with this, there will obviously be, this is again correlates with the extent of pancreatic necrosis. There will be fluid collections and they will go on to form their natural sequelae. The mortality rate almost is about 1/3. So 1 in 3 patients with this is likely to have a very high mortality at the end of 30 days. Can it cause something else? Yes, it can cause gastric or colonic necrosis. Because there is severe inflammation, you could have splanchnic venous thrombosis, portal or splenic vein thrombosis. Pressure on the bile duct can cause jaundice. There can be gastric outlet obstruction. And apart from that, almost every system in the body can get affected. So in that sense, severe acute pancreatitis is a systemic disease. It's not a disease which is localized to the pancreas. How do you score the severity? I think this is a very rough guideline, but basically there is a respiratory parameter, there is a renal parameter, and there is a cardiovascular parameter. You look at these 3 states, define a score, and at the end of that, you basically give a high score or a low score depending on what the situation is. So if you have a long-standing pancreatitis for more than 24 hours, more than one system involved, obviously you are in persistent organ failure, and this is not a good sign. So this is the latest classification, what we call as the Marshall's classification. There have been traditionally various other scoring methods, Ranson, Glasgow, Apache. I think we have all read this in our standard textbooks. But when you look at their positive predictive values, they just are, they fall short of 70%, which means that there is a limitation to these scoring systems. And that's why we don't really have rely so much on these scoring systems in clinical practice. And that's where CT scan and radiology comes so much in handy, because you really visualize the pancreas, and we have various scoring systems even on the CT scan. So what happens to once you get pancreatitis? Well, you initially get an inflammation. There is a collection. At the end of 4 weeks, you define whether that collection forms into a pseudocyst. So this happens in the simplest situations with pancreatitis. And the acute peripancreatic fluid collection, what we call as APC, either could be sterile or can get infected. It could increase or decrease over time. It may either entirely decrease and disappear, or at the end of 4 weeks, it usually forms a well-enhancing wall, and this is what we typically refer to as a pseudocyst. So there is a timeline to defining and understanding whether there is a pseudocyst present or not. And this is the same thing, that almost 50% of patients will have spontaneous resolution. 50% of these collections will remain static. And at the end of 8 weeks, if they form a well-enhancing wall, we would call it a pseudocyst. Generally, this suggests that the pancreas duct has been disrupted and there is a continuing leakage of pancreatic juice developing into a collection. And at the end of, therefore, 8 weeks, either this patient would be, one has to decide whether you want to deal with this endoscopically, radiologically, or through a surgical method. So sometimes you get, as we said, if you have a pancreatic necrosis, then you are dealing with essentially a necrotic collection. And at the end of 4 weeks, you define whether you want to, whether this is a pancreatic walled off necrosis or whether it is a necrosis which is as such. So we basically call it what is called as walled off necrosis if there has been an initial necrosis. So these are the two things. And as I again said, that if you have a walled off necrosis and pancreatic necrosis to start off, you can have it sterile. It can get infected very early on in the process of pancreatitis before 4 weeks. And the body can, initially it's a liquefied collection, it could become solidified. These collections can also decrease with time, but eventually most of them, the necrosis organizes itself, and this is what we typically refer to as WON, W-O-N, walled off necrosis. So this is in brief guideline, acute pancreatitis. Most of the times it's interstitial, 90 to 95% of the cases, 5 to 10% is necrosis. If you have less than 4 weeks, it's called a peripancreatic fluid collection. Beyond 4 weeks, we call it a pseudocyst. Less than 4 weeks, if it is necrosis, we call it simple necrosis. But beyond 4 weeks, once that necrosis organizes, we call it a walled off necrosis. And therefore, now where does imaging come? Normally, we ask for an ultrasound as the first investigation whenever any patient comes in with an acute abdomen. The same principle holds true for a pancreatitis also. And within the first 72 hours, if you are looking at a patient at the very first index presentation, CT scan may not have a role unless the diagnosis is in doubt. But the real role of CT scan comes at the end of 7 to 10 days, because that's the time when most of the complications begin to evolve. It's a time-dependent evolution. Or if you're seeing a patient at the very first instance who has a very high Ranson or an Apache score suggestive of severe pancreatitis, it is important that you carry out a CT scan to confirm the diagnosis and to rule out an underlying complication. Various methods to classify the pancreatitis on the basis of CT scoring have also been devised. I'll leave it to the radiologist to define it. But among the various criteria, one basically looks at how much the necrosis is, and one decides there is a Balthazar scoring system and a CT severity scoring system. But why I put up this slide is that there is a very good correlation of the CT score with the clinical prognosis. So the clinical and the radiological correlation is very well defined when you look at the CT severity index. So how do you manage such patients? I think the first thing is that we intensively fluid resuscitate the patient. There's a debate between crystalloid and colloid, but that holds true for any kind of a shock, but appropriate fluid management. The patients are usually in a lot of pain, so we give good pain relief. They may need a Riles tube, catheter, ICU care, oxygen support, etc. And we basically monitor them very closely through serial blood gases. And of course, if the patient is going into renal insufficiency, etc., without any delay, a renal replacement therapy, usually with CRRT. And we look at all the other biochemical parameters and continue monitoring the patient very closely. There are a few areas of interest. Do you use any measures like octreotide? Enough data now to suggest no role for real octreotide. Do you use any other things like snake venom, etc.? None of these things have proven to be useful at all. And it is essentially the natural history and the physiology of the patient which will define how the patient is going to perform. Any role for antibiotics? Yes, carbapenems have been known to be best used only when there is predicted severe pancreatitis or actual severe pancreatitis or proven sepsis. Otherwise, empirical antibiotics in mild interstitial pancreatitis doesn't really help. What about nutrition? Well, if the patient can take in oral feeding, one should allow oral feeding as soon as possible. Initially, the idea was that most of them get into ileus and avoid feeding, but we have now proven it has been proven beyond doubt through enough literature that early feeding actually helps in quicker resolution. It restores the gut microflora and helps out in preventing secondary sepsis. Should you do TPN versus enteral feeding? Well, wherever it is possible to feed orally or tube feed, it is better than TPN. But of course, if there is ileus, the patient can't tolerate feed, then there would be no choice but to continue TPN as a substitute till the gut is ready to take an enteral feeding. What do you do with antibiotics? Again, patients with pancreatitis have elevated inflammatory markers, white cell count and CRP, but these are markers of inflammation. They are not markers of infection. So if you don't have severe pancreatitis based on the criteria that we have just defined, prophylactic or empirical antibiotics are not indicated. What works best is when if you have a proven sepsis or if you have severe pancreatitis, then carbapenems, the meropenem group of antibiotics works best. Initial imaging of an ultrasound, we've gone through this, that it's possibly the best imaging modality as the first imaging modality, and particularly where you suspect gallstones and biliary pancreatitis, because it can identify the gallstone, it can see whether there is a duct stone in the bile duct dilatation, all these things. So in that sense, ultrasound is extremely useful. And again, when do you ask for a CT scan? At the end of about 10 days, that would be the ideal time, or earlier, depending on the clinical scenario. Now, the other thing is, would you do an ERCP? Yes, if there is a biliary pancreatitis, meaning, as I said, there is a documented stone in the bile duct. Very often you have situations where there are transaminitis, the bilirubin is slightly abnormal, the ultrasound shows a mildly dilated bile duct beyond 7 or 8 millimeters. This is the right patient wherein you would try to bring about a more defined imaging of the bile duct through an MRCP. And then, of course, if there is a stone occluding it, one has to carry out an ERCP to relieve the stone and to take away the cause of pancreatitis. Again, if you have biliary pancreatitis where the liver functions are resolving, you do not do an ERCP because the stone has already transited through, and doing an ERCP is not going to help unless the patient refuses a cholecystectomy. So again, as you see, this is an MRCP picture of multiple gallstones. There's a stone in the lower bile duct. The extreme lower end of the bile duct can't be seen because possibly the stone is there. And this is a typical case situation where you let the episode of pancreatitis settle down and you offer the patient a laparoscopic cholecystectomy in the index hospital admission. There is no point discharging this patient and telling them to come back in 2 or 3 weeks' time. We now know that the risk of recurrent pancreatitis is high. It is not cost effective, and you are subjecting this patient to more complications. So almost all international guidelines have now said that you should do the cholecystectomy at the index presentation. Otherwise, there is a 20% chance of getting readmitted within the first 4 to 6 weeks. So laparoscopic cholecystectomy, as we know now, it's a fairly standardized procedure. It's the gold standard for multiple gallstones. 5% of patients or less than them require conversion to open surgery. The chance of bile duct injury is extremely small, and therefore putting all the risk benefit into proportion and into the equation, I would offer a laparoscopic cholecystectomy to all patients with uncomplicated and mild biliary pancreatitis. Now, what do you do when you have infected pancreatic necrosis? So you can see the CT scan picture. Typically, the entire pancreas has been substituted by necrotic material. And this generally, as I said, it could be sterile or it can get infected. And this is exactly where you need a good CT scan and a good radiologist to predict the extent of necrosis and show us and map out the extent of necrosis. Now, under normal circumstances, we would just wait and let this necrosis evolve over time and chart out its natural course to see if it gets infected or if it gets localized. And again, as I said, if you have an acute fluid collection, we would watch it. A pseudocyst we would watch it, but here you can see that this has now formed into an abscess because there has been some secondary infection and gas into it. That requires intervention, that requires drainage. And of course, if you have a complete phlegmon, that will require a major surgical exercise. So you could have a sterile necrosis or an infected necrosis. There was a role of doing a fine needle aspiration to understand if that, and then send it for gram staining to understand if it had actually any infection. But this is a difficult procedure. The procedure of FNA itself can introduce infection, and therefore this has now been more or less given up. And what are the treatment options? We have the traditional open pancreatic necrosectomy, and now we move down to minimally invasive approaches, either through the flank or purely laparoscopic, or we drain it through percutaneous means. So again, you can see that this is a patient where there was a pancreatic necrosis very early on. There is a good peripancreatic fluid collection, and that has formed a gas towards the tail of the pancreas around the spleen. And this is the kind of drainage that our radiologists would put in. They would take the patient into the CT scanner and identify the area, and through a suitable window, insert one or more drains, and subsequently carry out regular scans to even upsize the drains and actually drain out all this infected necrotic material. This would be a surgical approach where you can put in a scope. It's like a rigid cystoscope or a ureteroscope through the flank. Again, look at it over the laparoscope and bring out all the necrotic material and the debris, as you can see there. Again, this is what is, this should be done at the end of 8 to 10 weeks, only if a radiological method is unavailable. And of course, if you resorted to doing an open necrosectomy, you can see this is an entirely necrosed off dead pancreas, entirely the shape of the pancreas, which was taken out at an open laparotomy necrosectomy. But we don't do this, we don't advocate this, and would do it only if we are compelled to, because the mortality is very high, almost 30% mortality. Any other complications? Yes, you can see this patient has got a pseudoaneurysm around the splenic artery. There is an abnormal arterial blush there. The pancreas digests off and takes away all the vessels, destroys the wall, and you can see actually this patient presented with pain and loss of hemoglobin. And this is a typical embolization that we resort to. This is the embolization of the gastroduodenal artery that this patient had, that had become aneurysmal because of the complete necrosis of the structures around the arterial tree. So we've discussed about pancreatic pseudocyst. This is a well-formed cyst, as you can see in the lesser sac abutting against the stomach. And there are various options where we have available. Either we could do a radiological or an endoscopic method to drain this particular pseudocyst. Very often these cysts cause pressure on the stomach and interfere with the digestion. That is fundamentally the most important reason why we need to drain them. And then, of course, we have a surgical method if the radiological or endoscopic methods at times are not best suited to the patient. Then we could do either an open or a laparoscopic procedure to drain the cyst either into the stomach, duodenum, or into the jejunum. At times, we may even need to carry out a selective distal pancreatectomy or resect of this particular cyst. So I'll just go through in brief. So as we said, mild attacks of acute pancreatitis, we need good ICU care, just paying very diligent attention to nutrition and supportive care. Where possible, do an ERCP followed up by an early laparoscopic cholecystectomy, antibiotics if there is proven infection, resort to enteral nutrition, and intervene whenever with appropriate means available to us through a multidisciplinary approach. I'll just spend the next few slides. I'm just coming towards the end on chronic pancreatitis. Now, this is again a disabling entity. We see that most of chronic pancreatitis, unlike acute pancreatitis, is alcohol dependent. So chronic alcohol use invariably leads to atrophy of the pancreas. There is a complete change in the pancreatic architecture, just like alcohol was induced changes in the liver and caused liver cirrhosis. By a similar mechanism, it causes intense fibrosis in the pancreas, and that leads to ductal disruption, ductal obstruction, and pain is the predominant element which dominates these patients. Unlike chronic pain, a failure to thrive, you have chronic backache, difficulty with food brings on pain, etc. And of course, then you could have duodenal, biliary, and venous compression. So the idea is that in such patients, you take away the offending agent, that is, try to get a good lifestyle change, support them with good analgesia, and hope that these measures will simply cause resolution of the pancreatitis or prevent attacks. But when things have gone too far, and we have now found that the pancreatic structural changes are such that the pain is intense, we then start thinking about how can we surgically relieve this. So in such situations, again, we have a variety of options depending on the clinical scenario. If there is biliary obstruction, we'll have to think of endoscopic stenting versus surgical relief of the obstruction. Sometimes you have a head of pancreas mass, can't really differentiate it from a cancer, and the patient would qualify either for a Whipple or for a distal pancreatectomy, depending on the situation and the site of the problem. And then there are various drainage procedures, what we call as a phrase procedure or a Beger's procedure. What fundamentally they mean is that we open up the pancreas. You can see that we basically opened up the pancreas along the pancreatic duct there longitudinally. There were stones present within the pancreas. This was the cause of ductal obstruction. You can see how dilated the duct is. Any duct beyond 3 millimeters we would call as a dilated duct. The stones are retrieved. This is what, and if we extended this opening up of the duct right into the head of the pancreas, that is what we would call as a phrase procedure. The other one is called as the Pustows procedure. And then this pancreatic duct is anastomosed to the loop of jejunum, and therefore some kind of a pancreatic or jejunostomy is done. The obstruction is taken away, the pain disappears, and at the same time we try to maintain the pancreatic exocrine function, because resecting the pancreas would mean that you lose the exocrine function. And if a patient is not diabetic, you risk the patient becoming diabetic. If the patient is not insulin dependent, then there is a chance that the patient then becomes insulin dependent. So I think I'll end my talk there. I've tried to go through most of the aspects of acute and chronic pancreatitis, and we leave the rest at the time of discussion. Thank you so much.
Thank you very much, sir.
Yeah. Sir, there is one question from the participant.
Yes, please. Yeah.
How to manage starvation ketosis with pancreatitis?
Yes, I think it is. It again has to be dealt with in a very medical way. I mean, pancreatitis. So I assume this patient would be having some degree of diabetes. So basically, the thing is that they would need IV fluids and hydration in the correct way, and presumably they are starving because of the pain from pancreatitis. So you take away the pain and try to resume the oral diet. At times, we also do what we call as a nasojejunal feeding. So this is the concept of what is called as a pancreatic rest. So what you do is that you insert a nasojejunal tube either at endoscopy or at fluoroscopy. The tube goes into the jejunum, and therefore, in one sense, you bypass the pancreas, which means every time that a patient goes on a diet, you're not stimulating the pancreas or provoking it to get inflamed. That helps in significant resolution of pain at times. And that will take care of the nutrition, and that will take care of the ketoacidosis or ketosis that is associated with starvation. But fundamentally, it has to be managed by a very diligent physician with a special interest in this, who will take care with appropriate IV fluids and dextrose supplementation and hydration.
Any more questions? Now from the panel, doctor? Dr.
Usha, yeah, there's one more question.
Yeah.
When we should go for surgery in asymptomatic gallstones?
Okay.
Yeah, so that's a good question. So when a patient comes with asymptomatic gallstones, you look at I would do some kind of an imaging. So let us say the ultrasound is done, the gallbladder wall is normal, the stones are innocent, there is no biliary obstruction, the liver functions are normal. After due discussion with the patient, you don't need to operate on them. But I assume that they have had an ultrasound. That's why they have been detected to have gallstones. So if you find there is any abnormality, like if there is a focal wall thickening, or at times the stone is just large and sitting on a wrong location, let's say at the neck of the gallbladder, causing significant distension or an over distension of the gallbladder, I would think that yes, you should discuss about the cholecystectomy, because almost 2 to 5% chance is there that these patients will become symptomatic over the next year. Secondly, in our country, in states where gallbladder cancer is endemic, the Gangetic belt, Bihar, Uttar Pradesh. So there is now there are a lot of proponents who say that yes, if you are living in that zone where there is a high chance of developing a gallbladder cancer, then you must have a prophylactic cholecystectomy. So so that is what we would leave. And of course, if you have asymptomatic gallstones with an abnormal liver profile, that means fundamentally the gallstones have caused you some problem at some point. It's just that you have not registered the symptoms. So again, in this situation, one would offer a cholecystectomy in this patient.
So there is one more question from the participant. How to diagnose insulinoma?
Yeah, so it's again on a very diligent clinical history. In fact, I have a little bit of neuroendocrine presentation at the end of this thing, so we can discuss it then. But fundamentally, it's on a basis of neurohypoglycemic symptoms. You see a lesion on the CT scan, hyper enhancing, do some basic studies, you'll be able to get a diagnosis.
Thank you so much for presentation.
Thank you.
Dr. Usha, I just want to tell the delegates, many of them are saying that the lecture was very good and they want to see it on the YouTube. So this will be loaded on YouTube in the evening. Those who are interested, they can just watch this whole CME on YouTube in the evening. Thank you.
Thank you. Thank you, Dr. Somil.
Thank you. Thank you very much.
Excellent presentations.
Thank you.
Now we'll move to the next speaker. The next speaker is Dr. Shivshankar Jalkote. He's a radiologist. To introduce the speaker, I request Dr. Dakshini Kashyap, and I am a CGP member, to introduce the.
Good morning, friends. Dr. Shivshankar Jalkote is Associate Consultant in Radiology at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. Dr. Jalkote did his MBBS from GMC Aurangabad and MD from KEM Hospital, Mumbai. He was Clinical Assistant and Clinical Associate at Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. Dr. Jalkote has received numerous awards during his academic career. To name a few, he received the first rank in all MBBS examinations at GMC Aurangabad. He also got the first rank in MD Radiology examination at KEM Hospital. He received state rank in 1 PGM CET 2012. He received the Best Resident Doctor Award in 2014 and was the Chief Resident of Radiology at KEM Hospital. He received Certificate of Merit in ESCAR 2018. His areas of interest are head and neck imaging, body imaging, onco-imaging, image-guided interventions, ultrasonography, conventional imaging, and PET and CT. Today, he will speak on the current status of ultrasound in pancreatitis. Welcome, Dr. Jalkote.
Am I audible?
Yes, doctor.
Yes, sir.
Yeah.
Yes. Sir.
Thank you so much. Thank you for a very kind introduction. Should I share my screen? Is my screen visible to everyone?
Yes. Yes.
Yes.
Yes.
So, thank you for following a wonderful talk on the clinical aspect of acute pancreatitis. My job has become further easy to talk on the role of ultrasound in the acute pancreatitis. Just a minute. I think it has stopped. I'll share again. There's some technical glitch.
Shiv,
Yes, sir.
hi. Some Swarup is also screen sharing. That is a problem. Swarup has to
It's going on.
stop screen sharing.
Yeah.
No, Dr. Jalkote.
Yeah. So we have discussed so far how the pancreatitis is diagnosed based on the revised Atlanta classification. The 2 out of 3 things are needed, out of which one is typical abdominal pain. Second is biochemical evaluation, that is lipase amylase, and the role of imaging as a third modality. So we know from the first lecture In most of the cases, the typical abdominal pain, lipase and amylase evaluation are enough for diagnosis of acute pancreatitis and don't need imaging for each and every case of pancreatitis. But there are atypical presentation, which can be atypical on clinical aspect or atypical on biochemical aspect. In this subset of patient, you need imaging to diagnose pancreatitis. The atypical clinical presentation can be patient with, typically what we see, the patient with acute pancreatitis have severe epigastric pain, which often radiates to the back. But the pain severity may not be necessarily always severe. And second thing, this location of pain can be variable, and that's the radiation of pain can be also variable. This typical pain is only seen in 50% of the cases, and at times pain can go to the chest, flank, and lower abdomen. And based on this, you can have a variable differential diagnosis clinically, which can simulate like an acute pancreatitis. When we talk about atypical pancreatitis, this is one entity which is described in literature where we call it as a painless pancreatitis, because this subset of patient may not have single pain, and this can be patient with SLE, old age patient, or rarely patient with post-operative subclinical complication. So when we see the literature and the textbook, this is the list of differential diagnoses given for the acute pancreatitis, which can include abdominal disorders, cardiopulmonary disorders. At times, the systemic disorders can have pain simulating like acute pancreatitis. So when we talk about lipase and amylase, these are the biochemical markers for the acute pancreatitis. There's variable sensitivity and specificity. To address this, the 3 times cutoff was introduced in revised Atlanta classification, which is very specific. We can see 97 to 99% specificity. But the problem happens with the sensitivity and positive predictive value, which is only 50%. And you can have lipase amylase normal in subset of patients, such as patient with hypertriglyceridemia, patient with extensive pancreatic necrosis, and less commonly in patient with very early pancreatitis, where the enzymes have still not elevated. In this subset of patient, imaging is important for the diagnosis of acute pancreatitis. We know serum lipase is not exclusive to the pancreas, and it can be elevated in other causes of pancreatitis. This is a list of differential diagnoses in which serum amylase can be elevated in non-pancreatic disorders, or there's a subset of entities where can be non-pancreatic causes in abdomen, which can cause elevation of amylase. For interest of time, I won't go through each and every list. You can read it through. This is the list given in the textbook of Harrison. When we talk about the lipase and amylase, we know the lipase is better marker for the pancreatitis, and the significant elevation of lipase is more often a diagnostic clue for the pancreatitis. But if you see, there are subset of disorders where there can be significant elevation of serum lipase, which may not be caused by pancreatitis, which include patient with the reduced clearance of physiological issues such as macrolipase, renal impairment, patient with non-pancreatic disorders, patient with critical illness, and patient with other abdominal disorders such as diabetic ketoacidosis and type 1 diabetes mellitus. This whole list is given in this current systematic review, which was recently published in 2015. So after discussing whole thing, we'll go on imaging acute pancreatitis. If I have to give one single option out of these 5 commonly used modalities such as X-ray, ultrasound, CT, MRI, and PET, which you think is the imaging modality of choice for the acute pancreatitis if you suspect patient with pancreatitis. So when you say, the answer is CT scan. CT is the imaging modality of choice in majority of the pancreatic diseases. When I say CT is imaging modality of choice, why I'm discussing on the ultrasound of pancreas? Because CT cannot be performed in all the patients of pancreatitis, because there are vulnerable subset of patients such as pregnant patients, children. These are very sensitive to radiation, and we should be very careful in ordering CT in this patient. Some patient can have contrast allergy, and this patient cannot undergo CT scan. There are certain advantages of ultrasound compared to the CT scan because it's more readily available. It can be performed portable. Patient in ICU, patient in ER, which cannot be mobilized to radiological department, you can take ultrasound machine and perform ultrasound in this patient. It doesn't require any contrast. It doesn't have a risk of radiation. It is easily repeatable and most importantly, is cost effective compared to CT and MRI. So this is the role of ultrasound in pancreatitis. We know the ultrasound is the most common investigation for evaluation of acute abdomen. This is also first line imaging modality for children and pregnant female. The key role in pancreatitis is to exclude the mimics of acute pancreatitis rather than diagnosing the pancreatitis. It is important in diagnosis of causes of pancreatitis, particularly the biliary tract evaluation for evaluation of the gallstones, CBD stones. It is important for follow-up of the peripancreatic collection, and you can perform the image-guided interventions using ultrasound. So this is how anatomy of pancreas is. In first year MBBS, we have read the anatomy of the pancreas. And if you have to draw, this is one of the best, simplest organ to draw in terms of the anatomy. This is uncinate, head, neck, body, and tail. But if you start drawing the relationship, the vascular relationship, we can see there are important structures surrounding it. The important are supramesenteric vessels. This is the gastroduodenal artery, splenic vein, and splenic arteries. Though it is easy to see, easy to draw, this is one of the most difficult organ by ultrasound to assess. And if you ask any radiology resident in first year, they will agree in first 6 months, most of them can't see pancreas on the imaging. And why this happens? Because the pancreas is deep seated in the retroperitoneum. There is abdominal fat followed by stomach, and pancreas is behind. Sometimes the colon can be anteposed to the pancreas, and in this case, there can be a lot of bowel gases, which will prevent evaluation of the pancreas. So this is how we can see on the imaging. This is your uncinate process. This is your head. This is your neck. This is the body. And this is the tail of pancreas. I must admit, these are kind of ideal pictures, and these are taken in patients who are thin built and medium built, where you can see pancreas in entire extent. But this is how a pancreatic duct can be seen on ultrasound. This is the pancreatic duct, which is not dilated. But in real practice, you must have read the reports where most of the people end up saying only head and body of pancreas is seen, rest of the pancreas is obscured. Like in this case, you can just see uncinate head and proximal body, rest is obscured. A good sonologist, what will do, he will try to displace this gas, try to compress it. In certain extent, you can see this, the part which was obscured can be better seen. So you can see additional part of body. To see the tail in certain number of patients, you can use splenic window. This is the tail of pancreas, which can be seen through the spleen, though it's not the very easy approach to do. Few number of patients, you cannot see pancreas, and you may have seen the reports saying pancreas obscured by overlying bowel gases. If you give water to this patient, this can improve the visibility. So in this first image, you cannot see pancreas at all. And the third image, same patient after giving water with adequate gastric distension, you can see beautifully the pancreas in entire extent. So one of the thing which makes evaluation by ultrasound difficult is the difference in the size, echogenicity of the pancreas with the age. This is slightly kind of isoechoic to the liver, but with the age, there is increase in the echogenicity of the pancreas. And the more often this pancreas looks hyperechoic in the old age. So I'll show you some of the examples of the acute pancreatitis on the imaging. This is how a normal pancreas should look like. In the first example, we can see a bulky pancreas. In the second example, you can see bulky pancreas with their internal heterogeneity. Normally, it's kind of relatively homogeneous. And third set, you cannot see a normal pancreas. Instead, there's a collection which is intrapancreatic as well as peripancreatic collection. So ultrasound can be helpful in diagnosis of acute pancreatitis in certain subset of case. This is a case of upper abdominal pain. Patient had acute pancreatitis in past, so he was sent for ultrasound to evaluate again any recurrent episode of pancreatitis. When we see This is how a normal gallbladder should look like. Thin wall, clear internal lumen. In this example, the same case, pancreas was normal, but patient had thick wall of gallbladder. You can see a lot of echoes within the lumen of gallbladder, and there is surrounding echogenicity. This bright area which is surrounding it is pericholecystic inflammation. There's some fluid. This is classical of acute cholecystitis, and this can be mistaken as a pancreatitis clinically. We have discussed the etiology of pancreatitis, and we by far know the most common cause is the gallstone, followed by alcoholism. In this aspect, the ultrasound is one of the great modality for evaluation of the gallstones. If I have to ask you, which is the preferred imaging modality of gallstone for the gallstone imaging, these are the four options: X-ray, ultrasound, CT, and MRI. Which one you will choose if you have to write one single imaging modality for the evaluation of gallstones? The answer is ultrasound. Ultrasound is the preferred modality, not the X-ray or CT. MRI is of good quality, but the problem with MRI comes with a lot of cost. These are 6 different patients which are showing gallbladder sludge, and you can see there are variable appearances of gallbladder sludge. This can be mild sludge, it can partially fill the lumen, at times it can completely fill the lumen. In some patients, this sludge can get organized and can look like a tumor. These are 6 patients showing different manifestation of gallstones. The gallstones can be variable in size, variable in number, like small stone here, you have few stones, you have multiple stones which are layered, which are we commonly call as macroalveoli. This is a large stone. At times you can have completely studded gallbladder. This often can be mistaken as a bowel shadow, and this may be go unrecognized in inexperienced hands of the ultrasound. So this is one example which shows how X-ray is insensitive to detect gallstones. These are the multiple gallstones. When we see there are no corresponding stones in the region of the gallbladder on the X-ray. So remember, only 20% of the stones can be seen on the X-ray, and rest all can go unrecognized. So please never ever order X-ray for the diagnosis of the gallbladder, though we can see commonly the kidney stones on the X-ray, but not the gallbladder stones. This is one example which shows CT scan at the level of gallbladder, and any radiologist, if you show this image to him, he or she will agree there are no gallstones. If I have to show the images of the ultrasound which were taken on the same day, you can see there are multiple stones within the gallbladder, but the CT can miss the gallbladder stones. So remember, almost 20% of the stones can go unrecognized on CT, but they can be seen on ultrasound. So don't get shocked when the CT radiologist doesn't mention the stone, when the ultrasoundologist has mentioned about the stones. So this is one of the limitations, and this is the reason you don't rely heavily on the CT scan for diagnosis of the gallstones. This is one patient where it was sent for biliary evaluation in case of pancreatitis. So far we know this is your gallbladder. This is an echogenic spot within the gallbladder, which can look like a stone. But when we rotate this patient, this was not mobile. If you see non-mobile structure, which is looking like a stone, but not a stone, you know this is a gallbladder polyp. This was a patient referred from outside for biliary evaluation, and the patient had a report saying organized gallbladder sludge stroke soft calculus. So when we saw, it looked like organized sludge or soft calculus, but one good habit is to put the color. And the moment we put the color, there is internal vascularity within the so-called sludge or calculus. Remember, none of the sludge aggregate or calculus should have internal vascularity. The moment you start seeing internal vascularity, you know you're dealing with the tumor. This was a gallbladder tumor, which was mistaken as a stone. This is one of the interesting case where you can see a serpiginous structure within lumen of gallbladder. If you see such kind of structure, you should be, what do you say, very interesting to say this can be a worm within the biliary tree or gallbladder, and this one can cause a recurrent cholangitis. Moving to the next case, here we see this dilatation of biliary tree. This is dilated common bile duct, and the distal end you can see a calculus. So this is the obstruction due to calculus causing dilatation of common bile duct and dilatation of the biliary tree. This is another example where you can see a dilated common bile duct. Distally, you have sludge, but this patient had a stricture on the ERCP. This is another case where you can see there's a small tumor within the distal bile duct causing obstruction and causing dilatation of the bile duct. But I must say the ultrasound is not the best imaging modality for evaluation of the distal bile duct because this part can get obscured and may not be easiest thing to do. In such cases, MRI should be performed. One of the things which is commonly sent for the evaluation is the evaluation of the stent. So this is how a metallic stent looks like. If you see the corresponding ultrasound images, even you can diagnose, even a non-radiologist can say this is the stent. Look at the internal morphology, which can be beautifully depicted on the ultrasound. So this is the metallic stent. In contrast, this is the plastic stent, which is slightly more difficult to appreciate. You can see this double line. This is the biliary stent, and this is the pancreatic duct stent, which can be evaluated with the ultrasound. Moving to the next case, this is a child who had a recurrent abdominal pain. This case was 2 years back when schools were open, and this child used to frequently bunk the school because of the abdominal pain, and he was counseled so many times. Eventually, he was taken to some physician who advised them to undergo ultrasound. And you can see this is the gallbladder, which is looking normal. And in this particular example, what do you see? This is the tubular dilated structure, which is like a fusiform like, and within it, there are multiple stones. So this is a fusiform dilatation of common bile duct with multiple stones. If you see this picture, you know you are dealing with the choledochal cyst on imaging, and which is a complicated choledochal cyst. That's the reason patient had a slightly bulky heterogeneous pancreas. This was a case of chronic pancreatitis resulting from a choledochal cyst with the stones. This was a 60-year-old male who had dull abdominal pain with mildly elevated amylase levels. When we did ultrasound, this is the normal pancreas. At the region of head, we can see there's a focal area which is separate from the adjacent pancreas, and this is a focal lesion. This particular image can show the difference of normal pancreas and abnormal focal lesion. It's slightly difficult to appreciate for non-radiologists, but if you see this kind of picture, you strongly suspect malignancy. So the dictum is, if you have acute pancreatitis in old age, one of the things which you want to always rule out is to rule out the malignancy. And these are the corresponding CT images where you can see this infiltrative lesion, which is consistent with the pancreatic malignancy. This was interesting case who came for annual health checkup, and this individual believed annual health checkup, and he used to do it religiously. This is the ultrasound images in 2017, where you can see a normal looking pancreas for his age. This is the ultrasound image of 2018. You can see there's a drastic difference in the pancreatic morphology. This is bright looking pancreas of normal size. In this contrast, this pancreas is bulky, relatively bulky, and the echogenicity from bright, it has gone to dark, what we call a hypoechoic bulky pancreas. If you see these kind of images, you can see the measurements almost has reached to 3.9 centimeter, and there's no internal vascularity within it. This patient was subsequently subjected to MRI. Based on the MRI and the clinical findings, the MRI was suggestive of autoimmune pancreatitis. The further workup confirmed this to be autoimmune pancreatitis. Remember, this patient came for health checkup. Patient didn't have a single symptoms. On the subsequent workup, he was found to have diabetes, and this case of autoimmune pancreatitis kind of clinically occult. And to show how ultrasound picture changed over a period of 2017, 18, and 19, I show the initial image. It was in 2017, normal pancreas. In 2018, we saw bulky black pancreas. In 2019, the pancreas is kind of returned to the normal size. This, whatever the size was increased, it has come back to normal. The echogenicity, which was black, turned out to be bright. And with this, you can see the how temporal evolution of case of autoimmune pancreatitis happened. In last talk only, we have seen the acute pancreatitis with fluid collections, which can be acute peripancreatic fluid collection if it is less than 4 weeks in interstitial pancreatitis, which can go on to become pseudocysts in few cases, while necrotizing pancreatitis in less than 4 weeks can have acute necrotic collection, which can get organized to form wall of necrosis. Not each and every patient of pancreatitis needs a drainage. Unlike other areas of the body where you see collection, you try to take out and do the sampling. These are the IAP, APA guidelines which deal with the management of the collection in patient with pancreatitis. We know this can be treated either percutaneously, endoscopically, or surgically. We have seen this in last talk. These are the certain indications. In the current era, where we try to perform minimally invasive surgeries, the ultrasound or CT can be helpful in the drainage of these collections. In that aspect, ultrasound is very important to characterize the internal content of the collection. So like these are the 4 different patients with collection, peripancreatic fluid collections. We can see this is completely black. This collection is most easiest to drain. This is a relatively thick, you can see black areas within this. These are particulate material. This still can be managed well. This particular subset has multiple collections, multiple septae, and the collections, which is more difficult to drain by simple image guidance. And this has the organized debris and thick wall. This is more further difficult to drain ultrasound, and this will need either endoscopic or surgical drainage. So this is how the ultrasound characterization can help in the evaluation of the internal contents of the collection and deciding the optimal management. So this is a case of acute necrotizing pancreatitis. Moving to the next case, this is a case of acute necrotizing pancreatitis. You can see this collection, this black collection surrounding the pancreas, which we followed up, and this, which was around 50 cc, had increased to 330 cc. On third follow-up, because patient was persistently symptomatic, the subsequent imaging was done, which showed there's increase in the collection, now which had gone to 423 cc. And the next follow-up, patient was significantly symptomatic, and here you can see the collection has grown to 1 liter, and patient had severe vomiting because of the compression effect of the collection. And this was drained initially by imaging. This patient had a ductal disruption, which was treated surgically. Moving to the next case, this was a case of acute pancreatitis. Initially, patient had very small pleural effusion. These are the images through the chest. This is the collapsed lung. This is the increase in the effusion, you can see. And third, you can see, compare the amount of effusion, it has gone significantly up. And this was initially drained under image guidance, but this patient recurred. There were a lot of increase in the significant increase in their effusion. If you see a recurrent pleural effusions of large volumes in a patient of pancreatitis, you should have one entity in clinical aspect to think about. And this is pancreaticopleural fistula, which can be seen in both acute or chronic pancreatitis. And this happens because the pancreatic enzymes are dissected into the pleural cavity. And this patient, even though they will improve in the abdominal aspect, they will have a significant amount of breathlessness because of the increase. So this is interesting case of pancreaticopleural fistula, which was confirmed on the CT. And this can be drained initially the simple needle, or sometimes you may need placement of a pictal drainage. catheter, which will allow drainage and before definitive management. One of the common indications for ultrasound is to evaluation of the vascular anatomy. And these are different images of the hepatoportal Doppler, where you can see normal patency of the portal vein, intrahepatic portal vein branches, IVC, hepatic vein. This is supramesenteric vein, and this is your splenic vein. So in this case of acute pancreatitis, you can see a bulky pancreas, but here what we see, this is the splenic vein. So normally splenic vein should look black like this IVC and aorta, but once we come slightly to the midline, instead of this black thing, you can see the echogenic material within the splenic vein. Put on the color Doppler, you can confirm there is no color within the splenic vein. This is confirmatory of splenic vein thrombosis, and this is one of the common vascular complication of acute pancreatitis. Another case, patient had acute and chronic pancreatitis. Patient presented with hematemesis, and when we did imaging on the CT, it was found to have splenic vein stenosis. Patient was treated. The stent was placed in the splenic vein. This is a splenic vein stent, and the ultrasound was performed to look for the splenic vein patency and a splenic vein stent patency. You can see colored Doppler images. The color is nicely going across. This tells the stent is patent. These are the these are spectral Doppler images. Same. Moving to the next case, this is 8-year-old kid with a recurrent abdominal pain, and his initial ultrasound was done outside, which showed right suprarenal cyst. So this was the adrenal cyst, but none of the adrenal cysts commonly present with a recurrent abdominal pain. So when it came for preoperative evaluation, we tried to find the cause of recurrent abdominal pain, and this is how pancreas was looking. So this is the splenic vein. You can see this black continuous line. This is nothing but a dilated duct. This is heterogeneous looking pancreas. You can see bright spots within pancreas. If you see these kind of bright spot, you know you're dealing with the calcification. So this is chronic calcific pancreatitis, and this patient actually needed management for the chronic pancreatitis rather than management for the suprarenal cyst. These are the corresponding CT images which show this is the suprarenal cyst. These are the calcifications, and this is the dilated duct. Chronic pancreatitis, the dominant investigation of choice is MRI with MRCP, followed by CT. Ultrasound has slightly limited role because morphology may not be always easy to depict on the ultrasound. And in this particular example of chronic pancreatitis, you can see a dilated duct. Normal duct is less than 3 mm. It was almost 5 mm here. This is second example of chronic pancreatitis, where you can see multiple foci of calcification, which tells about the calcific pancreatitis, which is again example of chronic calcific pancreatitis. Moving to the last case, this was an intestine case. This patient presented with pain in upper abdomen since 2 to 3 days. It came in late evening, and it was sent for ultrasound to rule out cholelithiasis. The junior on-call doctor who was there, and he performed the ultrasound. He took the images, and he called me saying, "Sir, it confirms there are gallstones. Should I send the patient back?" But as a rule, as an institution policy, we never allow patient to go back without having a senior evaluation. Once we saw there's certain things which were slightly odd. So in relation with the head of pancreas, there was some cystic lesion. I'll show you slightly zoom images. This is the stomach. This is the pancreas. This is the pancreas, and there's one cystic lesion in the relationship with the pancreas. So when I asked the junior, he said, looks like pancreatic cyst, which he has missed. But as a habit, should put color within the so-called cystic lesion. So when you put the color, this was picking up the color. So normal cyst should not pick up color. The moment it's picking up color, you know this is of vascular origin. So zoomed up images of showing that vascular entity which has color. There's a kind of appearance which is similar to Pepsi Cola. This is the Pepsi Cola sign, which you can see in this case. So this is seen typically with the pseudoneurysm. And this was indeed a case of gastroduodenal pseudoneurysm. Patient, picked up the phone, told the physician, and the physician asked patient to get admitted. But some patients are very adamant They don't want to get admitted. They think doctors are looting them. And patient went back to home, but he came within 3 hours with worsening pain and giddiness. And the CT was immediately performed because his systolic blood pressure has fallen to 60. And on the CT images, you can see this layering. This is typical indicative of hemoperitoneum. This is all hemoperitoneum in the pelvis, the upper abdomen also. And the cystic structure, which we diagnosed to be a gastroduodenal artery aneurysm, this was a gastroduodenal artery aneurysm on the CT. You can see it's leaking actually. And this is a case of ruptured gastroduodenal artery aneurysm presenting with the acute hemoperitoneum and instability. Luckily, the interventional radiologist was available. The patient was rushed to IROT and treated. These are the CT images. You can see this blob of aneurysm on the volume render images on the CT. And these are the pre and post procedure images. So the aneurysm was coiled successfully. And you can see these are the post coiling appearances of the aneurysm. And we could save the life of patient. So coming towards the end, I must admit, though whatever the pictures I have shown, these are in the best hands, but this may not be the case scenario in always possible because the ultrasound has certain limitations in imaging of pancreatitis. One thing is operator dependent, another thing bowel preparation, which is particularly a challenging in case of patient with the ICU. It can vary upon the body habitus. Early mild disease may be completely missed on ultrasound. It's not very sensitive to detect the necrotizing versus edematous pancreatitis, and we can miss smaller lesions on pancreatitis, smaller lesions on ultrasound. So in this whole last half an hour, I tried to show where the ultrasound is important entity in management of the acute pancreatitis. The main focus was to rule out the mimics of pancreatitis rather than diagnosing acute pancreatitis on the ultrasound, though it can be diagnosed in patients with children, pregnancy, and in unsuspected case of acute abdomen where ultrasound may be the first imaging modality to tell is acute pancreatitis. We try to evaluate the role of ultrasound in the biliary tract evaluation, which is the commonest cause of pancreatitis. We saw how ultrasound can help in the follow-up of the peripancreatic collection and how image-guided interventions can be performed. Thank you. Again, these are my acknowledgement. I must thank IMA, Dr. Karthik Ganeshan sir. He's my mentor, Dr. Saumil Vyas sir. He is wonderful gastrosurgeon and oncosurgeon associated with, and some of the cases are cases referred by him. And this is my current institute, Sir H.N. Reliance Foundation Hospital. Thank you.
Thank you, Dr. Shiv Shampad Jalkote. It was a very excellent representation. The ultrasound imaging was excellent. It was beyond our reach as a general practitioner, but you have explained very nicely and very well explained. Any question from the panel? Sir, in one figure you have showed the worms in the duct. How can we remove that one?
Oh, that's surgical, and in fact, that patient underwent cholecystectomy.
Okay.
Oh.
The biliary tree you can evaluate by ERCP, but the gallbladder, it was performed after cholecystectomy.
Okay. Any other questions from the panel, please? Thank you, Dr. Shivsham Jalkote.
Thank you so much.
Now we'll move to the next speaker, Dr. Swarup Nellore. I request Assistant Secretary, IMA CGP Sub-Faculty, Dr. Kajal Ahuja, to introduce the speaker. Over to Dr. Kajal Ahuja.
Dr. Swarup Nellore is a consultant radiologist at Sir H.N. Reliance Foundation Hospital and Research Center. After graduating from St. G.S. Medical College and KM Hospital, Mumbai, he completed his post-graduation DNB DMRE in radio diagnosis at Sir H.N. Hospital and Research Center. He procured additional qualifications like FRCR, Fellow of Royal College of Radiologists, London, and M. Medicine Diagnostic Radiology, Singapore. He practices cross-sectional imaging, CT, MRI, PET-CT, and X-rays, and his areas of interest include body imaging with focus on pulmonary and musculoskeletal imaging. He has been involved in national and international publications, peer-reviewed educational and scientific exhibits at international conferences, and won appreciation for the same at the international conferences like ESCR. He's also the primary author of 2 textbooks chapters in the forthcoming textbook of radiology by IRIA, Indian Radiological and Imaging Association. Over to Dr. Swarup Nellore.
Thank you so much, ma'am, for the kind introduction. At the outset, I would like to thank IMA Mumbai for giving us this opportunity to just try to showcase a couple of cases and maybe introduce the concept of pancreatic imaging to everybody. I would like to keep the entire talk as short as possible and not to have too many complicated technical jargon, because I understand that the audience would not really be interested in a lot of technical details that we would be talking about. Is my slide visible to everybody?
Yes, sir.
Yes.
Yeah. Thank you so much. Thank you, ma'am. So as we already heard from my previous esteemed speakers who have already spoken a lot about pancreatitis, talking about the clinical presentation of pancreatitis, we all understand that the typical clinical symptomatology of pancreatitis would be of a person presenting with epigastric pain radiating to the back. Of course, there would be associated biochemical elevations, and as Dr. Saumil has already projected very well, that there are cutoffs by which you take into consideration whether the patient is really having acute pancreatitis, and not just every mild elevation of the enzymes is taken as a biochemical marker. Imaging definitely has a role to play, as Dr. Shivsam had a very detailed talk on ultrasound, and he also talked about CT and MRI to introduce you. But basically, I would like to try to bring this talk to emphasize that the role of imaging is not always to diagnose the entity. A lot of times it is the clinical diagnosis which is taken into consideration, but there are times when imaging definitely has a role to play, and we will just try to cover up in this particular talk. So based on the clinical criteria, like you had both the Ransom score, Apache score, and you had what is called as the Atlanta imaging classification for pancreatitis, which basically classified acute pancreatitis and was revised later on in 2012. The advantage of this Atlanta imaging classification is that it helped us to give a more unified terminology from what the radiologist would explain to the report to convey to the gastroenterologists, the surgeons, and also for the pathologists to understand. So what are the different stages of pancreatitis? For example, you have an early stage of pancreatitis wherein the patient will present within a week of onset of symptoms. At this time, most of the times the pancreatic edema or ischemia is identified. Either it can completely resolve, it can progress to form fluid collections, or it can sometimes progress to form what is called as parenchymal necrosis or liquefaction. In this particular stage, the severity of the disease is primarily determined by clinical parameters, and imaging does not really have a very good role to play in such an early stage of the disease. On the other hand, as the disease progresses further, and we have maybe a couple of weeks to months after the disease has begun, the role of imaging has a lot more importance to play. That is why, because you need to identify, first of all, confirm the diagnosis of pancreatitis, identify the development of any local complications which can happen because of acute pancreatitis, systemic manifestations which can happen secondary to the pancreatitis itself, which can result in multi-organ failure. For example, renal shutdown being a very common thing for us to identify. So what is the role of imaging really to play in acute pancreatitis? One is you identify the diagnosis itself, or you identify an alternative diagnosis for the patient presenting with the symptoms. Now, as already been covered in the previous talks, a lot of common etiologies would include gallstones, alcohol, biliary ductal obstruction, or somebody even having a pancreatic ductal abnormality. The role of imaging also is important for us to understand not only the diagnosis of pancreatitis, but also to have what is basically grading the disease severity, and we will come to what is called as the CT severity index for the same. Then, of course, is to identify development of complications which can happen either within the pancreas or in the peripancreatic locations. And lastly would be to help us in guiding therapeutic interventions as and when required under ultrasound or a CT guidance. So when to do a CT or when not to do it. So a CT, if performed very immediately after the onset of symptoms. So as I told you, if it is done maybe on the day 2 or day 1 of symptoms, CT many a times might be absolutely normal, and we might be wrong in saying that the patient does not have acute pancreatitis. At the same time, all patients of pancreatitis need not really undergo a contrast-enhanced CT scan, and it is generally not indicated in patients who are having a very mild clinical presentation. On the other hand, it should definitely be performed in patients who are having severe pancreatitis or at risk of developing severe pancreatitis subsequently. The ideal timing of the CT scan should be about 72 hours after the onset of symptoms, because it helps us definitively to give the diagnosis on imaging. And at the same time, we can give a full extent of the disease, as what I will be talking about as the CT severity index. So this again talks to us about the indications of CT scan. One is the outset, when you do the initial imaging based on what all criteria we already have discussed about. The subsequent thing would be, when would you do a follow-up scan of CT scan in a patient of pancreatitis? So one would be either there is an acute worsening of the patient's clinical status, maybe 7 to 10 days after the presentation, if the initial CT severity score was less, or at the same time, if you want to assess the response to treatment after the patient has been given, would primarily be the indication of a CT scan. So as already has been discussed before, the CT scan is the most commonly performed investigation after ultrasound as the very initial outset. But CT scan would be a lot more sensitive, as well as a more specific investigation to do to diagnose pancreatitis. The other investigation, of course, in radiology, which we have, is MRI. So now we need to understand the balance between when would you perform a CT scan and when would you do an MRI. So if the patient has pancreatic parenchymal necrosis, a CT scan is not as sensitive as compared to an MRI. So in situations of acute necrotizing pancreatitis, yes, definitely an MRI would have an advantage. Also, the contrast which you use in MRI, which is gadolinium, has a better safety profile as compared to CT contrast in patients who already have a known drug allergy. But the main advantages of CT scan would be that CT scan is universally available in a lot many institutions, even in private diagnostic centers. It is very easy to perform because it lasts for a very short duration, and we have a 384 slice dual energy CT scanner at our institute, wherein the entire scan duration would be just a matter of seconds, not even minutes. So it is a very comfortable investigation for the patient to perform, and especially for a patient who is already in distress due to the symptoms of pancreatitis. But what would be the advantages of an MRI? So the advantages of MRI would be, of course, that there is no presence of radiation in an MRI. So that, of course, is a major advantage for patients who are having pregnancy. At the same time, to follow up in patients of recurrent pancreatitis who would require repeated imaging. And obviously, you would like to avoid unnecessary repeated radiation exposure to the patient. What are the limitations of an MRI? The duration of a scan. So a simple MRI investigation to be done to identify pancreatitis and also to incorporate what we call as MRCP, or a magnetic resonance cholangiopancreatography, which basically is talking about identifying the ductal system of the hepatobiliary and the pancreatic tree. This entire scan might last on an average for about 25 to 30 minutes. And for this, it is very important that the patient has to cooperate, because they have to have a very good breath hold. For a person who is obviously in an acute pain, this might not always be possible. Of course, on our machines, we have some newer sequences, which are what are called as single shot fast spin echo sequences, where even a patient who is not really that cooperative, you can get a reasonably good quality of image for us to diagnose. At the same time, there is something which is called as a respiratory gated MRI sequence, wherein the sequence is triggered based on the patient's respiration. So it is not necessary that the patient should actually hold his breath, but as the body movement takes place with respiration, we have something like a wire which is attached over the abdominal wall, which tries to coordinate the sequence timing with the patient's breathing movements. Of course, the disadvantage of an MRI could be that patients can sometimes be very claustrophobic, and of course, a lot of patients are not very comfortable because it's also a very noisy environment. Lastly, there are certain common problems which we can face, or movements because of respiration, because of peristaltic movements of the bowel, or vascular pulsations can cause interference with the image quality. So on the whole, as we understand from both of these, it is the CT scan, which is the primary investigation of choice most of the times in acute pancreatitis, and MRI would be used in selected cases and a lot more times in follow-up of patients. I do not want to go into too much of detail radiological anatomy, but they familiarize you with the basic anatomy which you could identify on a CT scan. The pancreas basically cannot be seen in one single section. So this is a horizontal section which has been taken at the level of the pancreas itself. We do not identify the entire pancreas in one single image, so we need to scroll across multiple images. But this basically would be at the level of the pancreatic body, and this is basically the pancreatic tail. So this is a contrast-enhanced CT scan image showing us the basic anatomy of the pancreas. Let us try to just understand that the pancreas normally should appear as bright as what is shown on this image, nearly comparable or slightly lesser as compared to the liver or the spleen. This is an MRI image of what we call as a pre-contrast T1 weighted image with the fat being suppressed. And what normally is seen is that the pancreas appears slightly more bright or nearly the same as compared to the liver, and should definitely appear brighter than the spleen. So this is a very important sequence for us to identify subtle abnormalities within the gland on an MRI. And basically, if at all the signal intensity of the pancreas appears dark on this particular sequence, it helps us to identify definitely that there is a pathology within the gland, and obviously would look at the scan with a lot more care. Certain common etiologies has already been discussed. Now, this is basically an MRCP sequence, wherein this we can identify is the gallbladder, and there are multiple gallstones which are seen within the gallbladder itself. A normal calibered bile duct, which we can see all across over here. Another patient, basically, where we do not see any obvious stones within the gallbladder itself, but we do see definite filling defects or stones which are there, which in the distal common bile duct, which can be identified here. And secondary to that, there is, of course, dilatation of the biliary tree, both in the extrahepatic location as well as within the liver itself. So common etiology of gallstones as a cause for pancreatitis. So what are the morphological types of acute pancreatitis? So now basically there are two basic etiology types of pancreatitis which can be identified on imaging. The first one is basically what is called as the interstitial or the edematous pancreatitis, wherein basically it is more of fluid which you see within the gland or surrounding the gland itself. Whereas the other counterpart is of necrotizing pancreatitis, wherein the gland breaks down and it results in what is called liquefaction or necrotizing pancreatitis itself. Now, based on the classification, we have certain terminologies which are here. So this again is also depending upon the time frame after the onset of symptoms. So if there are collections which are seen in which immediately is seen within the span of 4 weeks after the onset, typically in the edematous pancreatitis variety, it is referred to as an acute peripancreatic collection. After the 4 weeks, when this particular collection becomes well organized, by which we mean that it develops a very well-defined capsule or a well-defined wall, it is then referred to as a pancreatic pseudocyst. On the other hand, when we have a necrotizing pancreatitis developing, initially the pancreatic necrosis itself would result in a collection, and that of course would be called as an acute necrotic collection within. And this subsequently can become walled off or can become very well organized and is then referred after a period of 4 weeks as walled off parenchymal necrosis or WON. So this again is a table which just talks about it. I would not like to go too much into it, but just again reiterating the same facts that we have an interstitial pancreatitis where initially you would be calling it as an acute peripancreatic collection. Here, the fluid appears pretty much homogeneous, and subsequently after the period of 4 weeks would be referred to as a pseudocyst. In a case of necrotizing pancreatitis, initially the collection would be known as an acute necrotic collection with before 4 weeks of duration. The difference here is that this particular fluid is heterogeneous. So it contains some debris within it. So it will not be as homogeneous attenuation as what would be seen in an edematous pancreatitis. It may not be capsulated at this particular point of time. Subsequently, it can form what we have already described as a walled off necrosis. You can also get secondary infections within these collections, which is basically an indication for the person to then do a drainage of the collection, which, as discussed, could be done either by surgical means or could be done even by percutaneous means by imaging. So what is the modified CT severity index? So basically the CT severity index, as we were talking about, is for us to grade the severity of the pancreatitis. This is because it helps the clinician to get a fairly good idea as to what could be, in general, the prognosis of this patient in the long run. So the pancreatic scoring is done first taking the gland into consideration. So we take the pancreatic inflammation into consideration, and we have scores of 0, 2, and 4. So if we have a normal pancreas, the score is allotted as 0. If there is any alteration within the pancreas itself or peripancreatic fat, that would be given a score of 2. And if you were able to identify definitive fluid collections or necrosis, that would be given a score of 4. If there is frank pancreatic parenchymal necrosis, we also try to understand how much of the gland actually has necrosed. So based on the percentage of the glandular involvement, again, we have a scoring system of 0 to 4. And lastly, we look at the remaining part of the body, for example, the extra pancreatic complications, which would include development of ascites in the abdomen, development of vascular complications, like whether you could develop vascular thrombosis, typically involving the splenic vein, which is a very common thing to happen, or even a superior mesenteric venous thrombosis, or development of pseudoaneurysms, like typically the gastroduodenal artery, or the presence of pleural effusion. So presence of any of these extra pancreatic complications would give us an additional score. So the entire total score on a modified severity index would be out of a score of 10. Now, just coming to a couple of cases to just illustrate what I was talking all this while. So this was a 31-year-old who presented with clinical presentation of acute pancreatitis. So as we can see on this particular image, I'm sorry. Yeah, so as we can see on this particular image, this is the pancreas, which we can identify over here. So this is a contrast enhanced CT scan of the this thing. To start off with, let us try to look at the organs other than the pancreas. So here we can identify that the liver is darker as compared to the spleen on a contrast enhanced CT. The most common cause in our entity wherein this happens would be if there is fat deposition which would take place in the liver, and typically very commonly happens in alcoholic patients. Of course, we also have an entity called as NASH, where you have non-alcoholic steatohepatitis also developing in patients who do not take alcohol. But irrespective of what the etiology is, this basically indicates presence of fat in the liver, and many a times can be an associated cause for pancreatitis itself. Let's look at the pancreas itself. So we can see that the pancreas is showing a fairly good homogeneous enhancement. So like as I told you, the entire pancreas is not visualized on one single image. So these are multiple images that have been taken. So you can identify that the pancreas shows some amount of dark areas within the gland over here in the pancreatic body. But we use a criterion of 30 Hounsfield units. And basically, if the density of this particular dark area is less than 30 HU on a CT scanner, that would be an indicator of pancreatitis necrosis. On the other hand, if the attenuation is not less than 30 HU, then we basically would refer to this as presence of fluid or edema. So this typically is a case of pancreatic edematous pancreatitis. And we can identify the peripancreatic inflammation as this dark gray or rather gray line, which we can see surrounding the pancreas. This typically is what is called as the lesser sac, which is the space between the stomach in the front and the pancreas behind. Again, this image here showing the uncinate process of the pancreas, showing it enhancing really well. And we can identify the peripancreatic inflammation, which extends into what is called as the mesocolon over here. At the same time, you get thickening of the fascia in front of the kidneys. Basically, this is because the pancreas is a retroperitoneal organ, and there could be spread of inflammation, which can happen into the adjoining retroperitoneal structures as well as fascia. So this is a case of an acute edematous pancreatitis. Subsequently, as I already told, over a span of time, maybe typically 4 weeks after the onset of symptoms, the collections can get absolutely well organized. So you can identify this thin enhancing wall over here, which basically means that it's now a well organized collection. The fluid within the collection is fairly homogeneous. So this typically would be called as a pancreatic pseudocyst. And we can identify here that this pseudocyst is causing a mass effect on the stomach. This is basically the stomach which is getting pushed anteriorly by the pancreatic pseudocyst. Sometimes you can have extension of pancreatic pseudocyst also occurring into the mediastinum. So this is something that a radiologist should be aware about. On the other hand, if you have an acute necrotizing pancreatitis, why is it very important for us to identify this entity? The reason, of course, is that it would have a lot more complicated clinical course because the risk of local complications would be high and it would be associated with a greater morbidity as well as mortality. So now this is a patient who has presented with acute necrotizing pancreatitis. Now, how do we identify that? Now, this normally you should be able, this is the pancreas which we can identify here, very residual small amount of pancreatic tissue which is left behind in this patient. And most of the remaining parenchyma has been replaced by fluid. And the fluid here is not very homogeneous as what I had shown you on the previous scan. Again, we can identify over here that the fluid is very heterogeneous. We can see thickening of the retroperitoneal fasciae. But let us understand that most of the pancreatic parenchyma has got completely destroyed in the process. And that is the reason why this would be referred to as an acute necrotizing pancreatitis. Now, one of the complications, as I already talked about, would be vascular thrombosis. So this we can identify. This is normally the splenic vein, which should be appearing as bright as this on a contrast enhanced image. On the other hand, you see this dark filling defect which is there along the entire course of the splenic vein and also which is extending into the confluence of the splenic vein with the SMV. So this is a case of splenic vein thrombosis as a complication of an acute necrotizing pancreatitis. It is also important for us to identify the duct in such situations when there is disruption of the entire parenchyma. A lot of times the duct would be completely disrupted and it would then communicate with the fluid outside. And these patients would then present with what is called as an entity of pancreatic ascites, wherein repeated tapping of the fluid might not completely resolve and would require further interventions to be done in such a situation. Now, in the same case of pancreatitis, this was a follow-up scan which has been obtained a couple of months later. And we can identify now that we can see some presence of fat within the pancreatic collection itself and the fluid not appearing very homogeneous. You can see some enhancing septations which are there within the collection. So now this would be referred to as walled-off pancreatic necrosis. And we can just identify here, this is the gastroduodenal artery, which basically has got displaced by the collection. It has not yet thrombosed. There is no aneurysm. The artery is patent. But basically for the radiologist to identify complications of pancreatitis in the sense that this can sometimes result in ischemia because of mass effect which is causing on the artery itself. Sometimes in an unfortunate event, the pancreatic necrosis can get converted into an abscess, where basically now we can identify these dark areas is basically as presence of air. So you could get development of air within the pancreatic necrosis itself. And in this situation, obviously, it would be then referred to as a pancreatic abscess. Obviously, antibiotics would be the initial mainstay of therapy, but a lot of times these patients will not respond to antibiotics themselves. You would require a surgical drainage which needed to be done, either may be done laparoscopically or can be also be done by image guidance using an ultrasound or a CT guidance. I would just like to show one of the couple of images subsequently. But this basically is to show complications of how a particular pancreatitis can get converted into an abscess itself. So this basically is drainage of parenchymal pancreatic necrosis. You don't see any presence of any residual parenchyma at all. So this basically, and you can also see a well-defined wall to the collection now. So this is an ideal candidate wherein you can do a percutaneous drainage. So this is a very initial CT image which we have taken to identify where exactly the pancreatic necrosis is located. And subsequently, we introduce a guide wire. So we have a trocar, a single puncture set which we have. You can pass it like a trocar. It's basically a metal cannula which is inserted percutaneously. Here we are going in the intercostal space. This is the spleen. This, of course, is the colon. So we try to see that we do not harm any adjoining structures. Find a particular window through which we can enter the parenchymal necrosis itself. So we initially pass the trocar, puncture it, enter inside. And here over the particular trocar, we can see this bright structure, which basically is a pigtail catheter, is then railroaded over the trocar itself. Subsequently, after that, the trocar is removed and the pigtail catheter would coil inside this collection. We would then suture it to a drainage bag, and the pigtail catheter would be left inside till the patient is monitored serially, both of course clinically, as well as on ultrasound. We can do a follow-up or even on a CT scan to see what is the status of the parenchymal necrosis still. If there is significant resolution of the collection, obviously a pigtail catheter can be removed. If subsequently we see complications developing, like for example, we had development of an abscess, or you're having development of maybe hemorrhage within, you might then need to put more than one pigtail catheter as well. So the decision would depend upon what exactly would be the clinical progress of the patient. Just one single representative image where I'm showing about a case of pancreatitis. We do not see any normal pancreatic tissue here. You see a peripancreatic collection over here. And what we see here is basically a large gastroduodenal artery pseudoaneurysm. And on this scan, basically, you can see that this particular aneurysm is showing a part of it still filling up with contrast, and a lot of it is thrombosed. So basically, this is a large gastroduodenal artery pseudoaneurysm developing as a complication of pancreatitis. Now we have passed across the acute phase of the disease. And as we already discussed, there could be patients who could be coming with recurrent episodes of pancreatitis itself, and then of course would be presenting as a chronic pancreatitis. So this was a 25-year-old who presented with recurrent episodes of pancreatitis. And the very initial scan on the CT scan, which you can identify over here, basically shows a dilated duct. So typically a normal pancreatic duct should not be measuring more than 3 millimeters on the CT scan, whereas you can identify that the duct is dilated in the region of the distal body. And we can identify these bright structures here, which basically are the parenchymal foci of calcification, which typically are present within the duct. We can identify again the ductal calcification. I'm sorry for this. The ductal calcification, which you can identify in the gland. So this basically is a case of chronic calcific pancreatitis. In the same patient, we had also done an MRI, and this basically would show us that normally you should be able to identify some amount of pancreatic parenchyma in front of the portal vein itself, where we don't see here. So there is significant atrophy of the gland. So we do not see normal parenchymal tissue. At the same time, we can see on what is called as a T2 weighted image, we can identify these multiple dilated side branches of the duct itself. You can identify some ductal dilatation in the distal gland. And on the same thing, on the T1 weighted image, basically what I was trying to show initially, that a normal pancreas typically should appear brighter than the liver, slightly more brighter or equal to the liver on the pre-contrast T1 weighted image. Whereas here we can identify that the gland is showing a reduction in its overall thickness. At the same time, the gland also appears dark. This basically means that there is not only parenchymal fibrosis, as well as parenchymal atrophy, which typically would happen in a case of chronic pancreatitis. The same thing, we have what is called as an oblique sequence, which we do, coronary T2 weighted image sequence. Basically, we try to take sequences orthogonal or perpendicular to the pancreatic duct itself. And here we can identify this actually is the common bile duct in this particular patient. And at the same time, we can identify this multiple dilated ducts, which are seen in the uncinate process. And you can see a filling defect, basically, which is the calcification, or rather a calculus, which is there within the duct. So this is an image which is showing us on the MRCP that this patient is having calcific pancreatitis. The same thing on the MRCP image basically would show this is the common bile duct and this is the pancreatic duct. Typically, the pancreatic duct and the common bile duct both should join together at what is called as the major papilla. But in this particular patient, we identify that the main bile duct is going in a different direction as compared to the main pancreatic duct. And at the same time, we have what is called as the minor duct or the duct of Santorini, which is appearing dilated over here. And that opens into the duodenum into what is called as the minor papilla. So this is a case of pancreas divisum. So what I was talking about was a pancreatic ductal aberration, which can sometimes present as recurrent episodes of pancreatitis and typically is presents at a much earlier age in the patient. So this again basically just talks about what chronic pancreatitis would be. So we would be identifying presence of parenchymal fibrosis, atrophy of the gland itself, development of strictures or dilatation of the duct, and of course, development of complications like pseudocysts or aneurysms. Coming to another relatively uncommon entity, which is called as autoimmune pancreatitis. In these patients, many a times the patients would present with maybe pancreatitis itself, or they could also be having presence of jaundice. And they would be patients who would be presenting with diabetes mellitus in the very initial outset. On this particular CT image, we can identify what typically is described as a bulky sausage-shaped pancreas, wherein you can identify most of the pancreas over here appearing diffusely bulky. And you can see like a thin capsule which is surrounding the entire pancreas, which typically is a very pathognomic radiological feature for us to identify autoimmune pancreatitis. The reason why it is important for us to identify this entity is that, of course, we need to investigate and to confirm the diagnosis by the presence of antibodies, and typically IgG is elevated in these particular patients. The reason why it has a role to a diagnosis is because steroids have a very good role to play in these kind of patients with pancreatitis, which obviously would never be used in other patients of pancreatitis. So to conclude, I would just like to summarize again that the role of imaging for us is not only for diagnosing the pancreatitis, it is also to, of course, to identify the etiology, like the presence of maybe alcoholic fatty liver or the presence of gallstones, maybe identifying biliary strictures or identifying a pancreatic parenchymal or a ductal abnormality. At the same time, it is important for us to grade the severity of the pancreatitis itself for us to give us what is called as a CT severity index, which has an indirect role to play as far as the patient management is concerned. And of course, to identify complications which can happen secondary to the pancreatitis, and as and when required, play a role in therapeutic interventions like drainage. Thank you so much for a patient hearing.
Thank you, Dr. Swarup. There is one question from the participant.
Yes, please.
Okay, what is the cause of pancreatitis in a pediatric age group?
I'm sorry, I didn't get that.
What is the causes of pancreatitis in a pediatric age group?
Okay. Ma'am, so just basically to again talk about that. So in a pediatric age group, a common cause for pancreatitis would be the presence of maybe a pancreatic ductal abnormality, like what we had referred to as pancreas divisum. So because the pancreatic duct and the common bile duct basically would be having an abnormal aberration or developmental abnormality, these patients would have an easier tendency for the biliary enzymes to enter the pancreatic duct itself and trigger pancreatitis. So this is one important cause for a pediatric pancreatitis. At the same time, if the patients have maybe a congenital elevation of triglycerides, which indirectly would cause fatty liver, that could also be a cause for that. In patients of sickle cell anemia, you typically get what are called as pigmented gallstones, and these can be a cause for pancreatitis itself. So in adults, the gallstones which typically cause pancreatitis are cholesterol-laden deposits, whereas in children, this basically is because of development of pigments which happens in sickle cell anemia as a result of the vascular hemolysis which takes place in these children. That is why that could be a common cause for pancreatitis in this age group. These could be the very common causes for pediatric pancreatitis.
Sir, any relations with the diabetic, juvenile diabetic or type 2 diabetes?
Yes, ma'am. So basically, as I already talked about, that in these children, definitely the chances of the patient developing an earlier onset of diabetes mellitus would be more. Autoimmune pancreatitis definitely is one entity which typically tends to cause diabetes at a very early onset. So definitely, diabetes mellitus can definitely be triggered by recurrent pancreatitis itself.
Sir, pancreatitis is also an autoimmune category?
Yes, ma'am. So there is one basically, so a lot of times the pancreatitis which we come across is not of the autoimmune variety. So it is not a very common diagnosis, but yes, we definitely have come across quite a few cases at our hospital as well, wherein autoimmune pancreatitis can be a manifestation as well. The same autoimmunity can play a role in multiple other organs, but at the same time, it can involve the pancreas too. So autoimmune pancreatitis is definitely an entity which we need to be aware of. And typically, it is also described as IgG4 associated pancreatitis, which basically talks about the presence of the immunoglobulin, which is elevated in these patients, which causes the pancreatitis itself.
Okay, thank you so much. Your presentation was far excellent.
Thank you, ma'am. Thank you so
You
much.
had explained this very nicely at a GP level. Thank you so much, Dr.
Thank you, ma'am. Thank you so much. Thank you.
Now we'll move to the next speaker, Dr. Karthik Ganeshan. Can we have a Now, Dr. Karthik Ganeshan is a consultant radiologist and division chief of the body imaging at Sir H.N. Reliance Foundation Hospital and Research Center. After completing his MBBS and DNB, he successfully accomplished fellowship in MRI and fellowship in advanced liver imaging from the University of California, San Diego. Throughout his illustrious academic career, he received several scholarships, including the Amar Gandhi Scholarship for Best Clinical Associate in Jaslock Hospital and Research Center and J.N. Tata Endowment Scholarship. He has also received the Har Gobind Foundation Medical Fellowship. He has several peer-reviewed and index publications to his credit and peer-reviewed scientific abstracts and educational exhibits and posters. He was also awarded the Best Poster Award by the Society of Abdominal Imaging in 2013. He is the co-author of Hepatic Iron Overload in Abdominal Imaging. He has also authored 2 chapters in cross-sectional imaging of abdomen and pelvis by Springer Publications. His special interests are body imaging, head and neck imaging, and neuroimaging with functional MRI. Today, he will be conducting first a case discussions, followed by which he will be talking on pancreatic cancer, state-of-the-art imaging. Over to Dr. Karthik Ganeshan.
Good afternoon to everybody. Am I on?
Yes.
Yeah. So first of all, I would like to thank Dr. Jitesh Mehta and the entire IMA team for organizing this wonderful session on pancreatic imaging. And we've got a huge number of delegates. So thank you so much to Dr. Mehta and his entire team. At the same time, I'd like to take the the co-delegates, Dr. Vyas, who is my co-surgical colleague at HN, and then 2 of my colleagues in my team, Dr. Shivsam and Dr. Swarup, who have just in tandem spoken on ultrasound and CT. What I'm going to do for the next about 15 or 20 minutes, I would request all the 3 delegates to be unmuting themselves so that, I can serially put forward the questions to the individuals. What I'm going to do, Dr. Mehta and the rest of the IME team, is that I'm going to try to get about 3 case scenarios, which would be very interesting for the rest of the delegates who are attending this session, on how we actually manage these cases of pancreatitis on a day-to-day basis. And I would be posing these questions in sequential or a non-sequential order to the remaining panelists. So I think Somil, Swarup, and Shivsam, are you on? All of you guys, please.
Yes,
Karthik.
Yeah, hi. Good morning to all of you all. And what I'm going to do is I'm going to start with 3 scenarios, each of about 6 to 7 minutes. Please keep your answers succinct and to the point, and so that it makes and of course, if there are any questions coming in from the delegates, we can definitely, or the remaining participants, we can push it forward to the clinical team as well. So we're going to start with 3 scenarios. Scenario number 1, and this we're going to start it off with soft cost, because from the clinical point of view. So Somil, there's a patient who's coming to our ER. He's in his early 30s. And he has been presenting, or he's been complaining of upper abdominal pain localized to the epigastric and the right hypochondrium. The pain is of severe onset, severe intensity, but of recent onset, a day old. And it is accompanied by some degree of upper GI upsets or symptoms in terms of nausea and vomiting. And his initial blood tests have shown a combination of 2 important features. One is an elevated white blood count, which is at 14,000.
and also got lab markers which are favoring pancreatitis in the form of hyperamylasemia, hyperphasemia in the form of more than 3x the normal value range. So in such a scenario, you're called in by the ED, what would be your clinical approach, and what would be your ancillary diagnostic texts you would be asking for as the clinician who's looking at the patient? Somil, up to you.
Yeah, thank you, Karthik. So I think we would follow the basic ABCs, clinical examination, make sure the vitals are stable. And after all that, the blood markers are already there. I would ask for a basic chest X-ray, rule out gas under diaphragm. I think that's fundamental with any acute abdomen. And then ask for an ultrasound of the abdomen and the pelvis.
Okay. So thanks, Somil. Shivsam, are you around?
Yes, sir.
So now you have got the plain radiograph of the chest as well as probably the upper abdomen in an erect position. That would be something which is very important, not on a supine, but an erect abdomen. And the X-ray shows absence of air under the diaphragm. And now, so you're ruled out you've ruled out, or the potential of a hollow viscous perforation is lower on the cards. And now you're doing an ultrasound. What would you be looking for in such a scenario, especially keeping in mind the clinico-pathological backdrop in which you're doing the imaging? And what is the information you would like to give? Please share.
Yeah. As the clinical information is very much suggestive of acute pancreatitis, based on the lab investigation and the patient presentation, we'd like to first confirm whether this is really acute pancreatitis. So in imaging, the important thing which we do is to see the pancreas, whether it's really bulky. Second thing, to see any amount of peripancreatic fluid collection, which can turn into in further course, it can turn out to be peripancreatic fluid collection or necrotic collection. So that information is so important. Third thing, when we talk about what is the status of the biliary tree, is the bile duct dilated or not. Fourth thing, we'll talk about the any stones in the gallbladder or any stones in the dilated bile duct, if it all is there any degree of biliary dilatation? An additional thing we see commonly, if at all possible, to see the vascular patency. That will be a good amount of information for most of the initial evaluation of ultrasound in suspected case of pancreatitis.
Thanks, Shiv, for that answer. Now that you know that this is pancreatitis, what would be your sine qua non imaging features which would help you go towards a diagnosis of pancreatitis, irrespective of what you're seeing on the gallbladder or the biliary front? So what would be the possible appearances of the pancreas in an acute setting within the onset of ictus being 24 to 48 hours?
See, most commonly, what we can see, depending on the severity of the disease, the manifestation can vary. If it is very mild disease, we may at times see a normal looking pancreas, though there's a background clinical diagnosis of pancreatitis. Commonly, the common entities are the pancreas looks bulkier than what is the normal reference range. We use a different cutoffs for the age and age matches. Second thing, we can see there's some kind of heterogeneity surrounding the pancreas. Usually it's a peripancreatic inflammation, though this is best seen on the CT scan. Third thing, we can see some amount of fluid surrounding the pancreas. At times, we can see fluid tracking into the other recesses of the abdomen and pelvis.
Yeah. So
hello, Dr. Ganeshan.
Yeah. So
do you have any slide, or are you sharing any slides? Because
no, we won't share any slides now, because already the three speakers have spoken enough. So okay. I will just kind of summarize whatever is the discussion going on forward. So one important thing for the delegates is to understand is that if you image very early in pancreatitis, you can get a normal pancreas, and in a substantial amount of patients who have got mild acute interstitial pancreatitis, where the amylase and lipase are just marginally elevated, or probably even if they're 3x elevated, the pancreas can look completely normal on imaging. So please understand, don't be surprised if you get a report from a sonologist or even a cross-sectional radiologist saying the pancreas is completely normal, but the patient has got abnormal pancreatic enzyme. So I think that's a very important takeover. Now, the next question which I have now to Somil. Somil, you're there?
Yes, yes.
Now that you've got the ultrasound feedback, the points are there. What would be your future course of action? And would you be using any other imaging to take this forward? Probably you can say 48 to 72 hours now after the ectus.
Yeah. So I think one thing is that we always have a good interaction with our radiologists, and this is where doing the imaging with a dedicated pancreatic radiologist or somebody who has an interest in the subject. So of course we would discuss these findings with our radiologists, as we always do. And at the end of the putting clinical hematology and radiology all together, this patient has got mild acute interstitial pancreatitis, and he should be treated with the standard parameters and kept under close observation. I would not ask for any further imaging at this point in time.
Thanks so much. So that's a very important take-home message. Mild symptoms, mild elevation or distortion of the pancreatic enzymes, imaging can be negative. You do not deal with the patient based on the imaging parameters, but you primarily look on the clinical lab parameters and then decide the future course of action. Now, to bring in Dr. Swarup, if I would ask you, if in this case, the patient has actually worsened in terms of the lipase and amylase have gone up, the WBCs remain distorted or elevated, there's any other symptomatology coming up in the form of fever, the patient is not doing clinically well, and Somil has now asked you to get a CT done. Two questions to you. What would be your protocol for the scanning, which is very important to be informed to the participating delegates, and what are the typical imaging features which may or may not be seen in patients with acute mild or acute interstitial pancreatitis?
Yeah. Yes, sir. So basically, what is important for us to understand is, of course, the scanning protocol, which typically would be doing what is called as, of course, you can have a plain scan, which is not mandatory to be done on a dual energy scanner, which we have at our institute. But at the same time, the contrast enhanced CT scan definitely would be an important investigation or tool to play. Unfortunately, if the patient is having a deranged renal function, you may then decide whether you would really be able to give contrast or not. Otherwise, if the contrast is given, we would then give it in particular phases, what is called as multiphasic CT scan, where you have an initial arterial phase, which is performed typically about 22 to 25 seconds after the contrast injection is given. In our organization, we can do with a small amount of contrast considering the speed of the machine. So a very small amount of contrast medium is enough for us to give us the diagnosis. So the arterial phase would help us to identify any kind of an arterial complication which can happen due to the pancreatitis itself. Then, of course, you have a parenchymal or a pancreatic phase, which typically is done at about 35 to 35 seconds after the contrast injection is done. And this is a phase where we would be able to identify parenchymal involvement of the gland a lot more better as compared to the arterial phase, wherein normally the pancreas would not enhance. So you would typically wait for about 35 to 40 seconds after the injection, and you would see normally the parenchyma should be showing a very homogeneous enhancement. But if you see any dark or what is typically described as hypoattenuating foci within the gland, that would be a suggestion that either there could be presence of edema or necrosis within the gland during this particular phase. And of course, the subsequent phase is a venous phase, which is done typically again about 55 to 60 seconds after the contrast injection, wherein you will be able to identify vascular involvement involving the venous channels, for example, involvement of thrombosis of the veins itself, like the splenic vein, the superior vein, and if at all that extends or propagates into the portal vein itself. Now, coming to how we would be diagnosing the pancreatitis on the scan itself, as I talked about, on the parenchyma, you might sometimes see dark areas which are enhancing or not enhancing. So if the area which is dark on the gland does not show attenuation less than 30 HU, that typically means that the gland has still not necrosed. And that typically is what is seen in an acute interstitial or an edematous pancreatitis. On the other hand, if the gland basically shows parenchymal necrosis, you would expect a lot more heterogeneity to take place, a lot more liquefaction of the parenchyma, so wherein the attenuation would then significantly change. That is one. Then, of course, you will also see inflammation surrounding the pancreas. So you could be able to see a fluid which can extend into all the recesses of fascia. So there could be involvement of the gland itself or the peripancreatic involvement. And subsequently, this can also cause necrosis or the fat which is present in the peripancreatic tissue, which is typically called as necrosis. So this is so involvement of the gland as far as sorry ma'am, I'm audible now?
Yeah, but it's cracking.
Please keep the mic a little away because it is overreacting.
Fine.
Yeah. Yeah.
Okay.
Okay.
Swarup, so I'll just so I'll just kind of take over here. So don't mind.
Yes,
See what Dr. Swarup is very succinctly tried to mention out here is that the spectrum of features can be very wide. It can be a normal pancreas. It could be just a mildly swollen pancreas, or it could be areas which could show evolution over a period of time from just inflammation to necrosis of the pancreas, and that not only of the pancreas but the surrounding peripancreatic fat and of course the vascular channels. Now, one very important take-home message from this entire thing for the audience out here, which I would like to very clearly say, whenever you're suspecting a patient with pancreatitis, do not ask for a plain CT scan. You must ask for a contrast enhanced CT scan, and it should be a multiphasic contrast so that you can assess the gland and the surrounding periglandular structures very, very clearly. Now, back to you, Somil. How would you follow up this patient? And would you want to look for any further complications in the future? That's it. Yeah.
Yeah, so I think once this patient has had a CT scan in the light of a rising white cell count, one would continue treating him conservatively, and I would offer him a surveillance scan earliest at the end of 4 weeks from the index presentation, or earlier depending on the clinical situation. But he definitely would merit a follow-up scan at the end of 4 to 6 weeks, in keeping with the timelines as we described by the Atlanta classification. So that's what I would do.
So that's a very important take home. So just a summary of the first case: patient with suspected mild pancreatitis. Ultrasound is it's a clinical diagnosis. Ultrasound is the first imaging modality. Imaging done very early, between 24 to 48 hours, can be completely negative. You don't need to do cross-sectional imaging if the patient is clinically and laboratorically fine or just showing mild derangement or mild symptoms. Only if the patient worsens in terms of clinical or laboratory parameters do you want to do CT. If you're doing CT, you have to do it as a multiphasic contrast CT, not a plain scan. And the ideal time to do this scan is between 48 to 72 hours. The further you push it to day 3, the better is the amount of inflammation which you can easily pick up on the CT, quantify that inflammation and look for any areas of glandular necrosis or peripancreatic inflammation. So that's a very important take-home point. Lastly, what Dr. Somil said is also important, that you need to follow up these patients typically at about 4 to 6 weeks interval for 2 reasons. You want to see resolution of symptoms as well as imaging features. And at the same time, you want to pick if there's something underlying in the pancreas which is causing the pancreatitis to develop. So any structural abnormality in the gland or in the duct, or any other abnormality in the vicinity of the pancreas which is causing the symptomatology. So let's go to case number 2 or scenario number 2. That's very important. So here we have a patient who is a 44-year-old gentleman who presents with a BMI of 27, who's presenting to the ER in the form of an acute abdomen, epigastric hypochondrium pain, severe associated with vomiting, and also tachycardia. Somil, after you, what would you do in this case?
Yes, so again, the basics, ABC, clinical examination, followed by plain erect radiographs of the chest and abdomen, and then a complete hematological and a biochemical blood profile, including a complete liver function, amylase, and lipase.
Okay, so once you've got this done, these are the blood reports. The AST is 214, the ALT is 198, the bilirubin is 1.7, the gamma GGT is mildly elevated. However, the lipase and the amylase are through the roof. They're more than 3x the normal. Lipase is 744 and amylase is 1433. What next from you, Somil?
Yeah, I would call up my radiologist and ask him to do an immediate ultrasound in the first instance.
Okay. Dr. Shiv, in view of the symptomatology and the blood as well as the LFT pancreatic enzyme levels, what would you be expecting to see on ultrasound, and what do you think you should be looking for on the ultrasound?
Here the important clue is the lab investigation, which are pointing towards the derangement of the liver function test and the bilirubin. The moment you see this information, we should be suspecting any kind of underlying biliary abnormalities, which can be contributing to the underlying pancreatitis. Here we see the diameter of common bile duct. If it is dilated, we try to find out their level of obstruction. So if it is common thing which we see end up in saying is choledocholithiasis, where the stones in bile duct will be seen. So we will try to see the bile duct in entire extent using a different maneuvers. At times with patient with obesity, it may not be necessarily so easy, but we'll give a full attempt to try to see and find out the stones in the entire biliary tree, ranging from distal common bile duct to the proximal bile duct, as well as in the gallbladder. So if any obstruction is seen, we'll try to measure the diameter of the bile duct, try to quantify the degree of obstruction, and based on these findings, we'll communicate with the clinician whether we're able to see the definitive cause of obstruction. If not, the further imaging modality will be needed after discussion with the clinician.
Okay, so one question to you, Shiv. Suppose you have an obstruction and you have a dilated bile duct, but the IHBR is not dilated. Will that push you away from the diagnosis, or would you still expect this to be a bile duct stone sitting down below?
This is very important thing. We need to have a normal cutoff based on the age. So if you're seeing a dilated bile duct in the age below 40, that is definitely abnormal. Up to 7, sometimes up to 8 millimeter people take it. But if it's dilated, no matter whether there is dilatation of intrahepatic biliary radicus, because in early cases or mild obstruction, particularly that because of the sludge, can hamper the degree of dilatation, and that should not restrict us from evaluating for the possible small calculi or sludge within the distal bile duct. At times, you can have low-grade strictures which can be completely occult on the ultrasound that warrants the further image.
That's a very good answer. And just to reiterate to the delegates and the participant here, IHBR dilatation takes a much longer time to develop as compared to dilatation of the bile duct, which is the extrahepatic bile duct. So when you have in an acute setting, the only thing which you may see is a dilatation of the extrahepatic duct. IHBR will not be dilated. So if you all guys get to see ultrasound reports which says that IHBR is normal, but the extrahepatic duct is dilated, for the patient age, you have to still make sure that you want to rule out a bile duct calculus in the setting of a biliary pancreatitis. Another take-home point out here, which is very important to remember, is that an easy way to measure the diameter of the duct is if you take the age, you add +1 to it. Ideally speaking, it should not be more than. So for a 45-year-old man, the maximum diameter which is permissible is about 5 to 5.5, max up to 6. Anything beyond that has to raise an index of suspicion. Now, Somil, you have got the clinical picture, you have the hematological and the blood profiles, you are suspecting a biliary pancreatitis, the ultrasound findings are heading towards that diagnostic yield. said that this could be a biliary pancreatitis, what would be your thought process from a clinical point of view, and what is the next investigation you will order so as to get to the diagnosis?
Yes, so two things. I would look at the trend of liver function to see if the bilirubin is increasing or decreasing over the next 24 to 48 hours. And number two, it is almost inevitable that this patient will need a dedicated imaging of his bile duct in the form of a MRCP. I would speak to my radiologist to get an MRCP.
Okay. So, Swarup, one question here for you. If you're looking for assessment of the biliary tree per se, which is the imaging modality of choice? Is it CT or is it MR, or do we use a hybrid approach to assess this entity or this structure, anatomical structure?
Yes. So if a single investigation has to be done to identify the biliary tree much clearly, undoubtedly it is MR, and basically MRCP should be the investigation of choice to identify the biliary tree. But at the same time, we do have a hybrid approach because there could be instances wherein there are certain findings which are identified much better on a CT scan or even on an ultrasound. For example, if you want to look at gallstones, there could be gallstones which are not identifiable on a CT scan. So it is very important for us to understand that radio dense gallstones can be identified on a CT scan, but whereas there could be a lot of stones which are radiolucent and the CT scan would be absolutely normal. At the same time, although an MRI or rather an MRCP will be able to identify gallstones, there could be instances when the stones are really very tiny and not really identifiable easily on the MRI. And in such a situation, it is undoubtedly the ultrasound which should be the main investigation to identify the stone itself. Also, there could be sometimes just presence of what we call as hyperconcentrated bile or sludge, wherein the stone has not really formed. And what you would just see would be layering of sludge within the gallbladder lumen itself, or sometimes within the terminal duct, which can be identified very well on the MRI, not so on the CT scan, not maybe even so well on the ultrasound, but definitely on an MRI, and especially what we call as T1 weighted images, where we would see the bile to appear much more brighter than normally what it should. So you would be able to identify that better on an MRCP. So definitely MRCP as one single investigation, but otherwise as a hybrid investigation, we need to put all the investigations together to get a complete answer.
Thanks, Swarup. So, Somil, you've got the patient to have bile duct calculi with some sludge, as well as gallbladder calculi with some sludge. How does the MRCP findings, along with the progressively rising bilirubin level, now influence your management in this case of pancreatitis?
Yes, Karthik. So I think, so ductal clearance then becomes mandatory, and this patient would be referred for an ERCP sphincterotomy and clearance of the bile duct before he has his cholecystectomy. There would be a group of proponents where people do laparoscopic cholecystectomy with CBD exploration. But in most units where you have a very good endoscopic facility, this is the treatment of choice. So this is how an MRCP actually allows you to do an indicated ERCP and prevents what can be a needless ERCP, because you don't want to do an ERCP if you don't have a biliary obstruction, because there are complications associated with the ERCP itself.
Yeah, so that's a very, very good point for the panelists, as also the delegates out here, that if you have a proven cause of obstructive biliopathy with non-invasive imaging, and that's the role of MRCPs and CTs, then you need to take it away from a non-surgical management. You require an endoscopic evacuation of the biliary tree to decompress the biliary tree and allow it to settle down. And following which, then a surgeon like Somil would come in and then take out the gallbladder at an interval period. So this is what we call an interval cholecystectomy. And that would be, again, purely clinically driven in terms of how the patient is following the ERCP itself. So that's a very important take-home point out here. The last one, I'll do another short 5-minute case capsule, where this is a 65-year-old gentleman who has presented to us with clinically proven acute pancreatitis in the hospital ED. The pancreatic enzyme levels are elevated. They're proven pancreatitis. And now he was admitted in another hospital in an ICU setting. He was not doing well. And because of that reason, he was pushed in towards a tertiary care center like ours 24 hours after the onset of the ictus or the symptoms. The imaging done elsewhere showed sine qua non features of acute pancreatitis, but there was not much or any, or there was some amount of peripancreatic inflammation, but there was no evidence of any other abnormality on the scan itself. So you had acute pancreatitis along with a lot of peripancreatic inflammation. We didn't have what we call as the modified CT severity index. Now that's a reasonable score to quantify the amount of pancreatic involvement, but it does not do so well when it comes to peripancreatic necrosis. That's one thing with CT that we can't quantify it. Now, with this information, and along with the fact that she has got other comorbidities like hypertension, diabetes, prior intervention in the coronaries in the form of an angioplasty and stenting, Somil, as a clinician in the ED, what would be your thought process and how would you want to tackle this patient? And would you want to do anything further when this patient comes to you?
Yes, so again, I would stabilize him either in a ward situation or ICU, depending on my clinical assessment. But I assume that if this gentleman has been in another hospital, not doing very well, and it's been a number of days, he would be in ICU. And I would subsequently ask for a CT scan with contrast under ideal situations.
सगळ्यात मी तो त्याला पाहिजे करतो तो विचारत
Somebody
पण
will have
नाही.
to mute on the
त्याने
background.
त्यांनी उदाहरण सांगतो
Somebody's voice is
Somebody's
फाडायचे आहेत.
Dr.
मला पण जीव आहे.
Dr. Girishland.
Yeah. Okay.
Yes, yeah. So I would, after stabilizing the patient, I would, under ideal situations, ask for a CT scan with intravenous contrast, subject to the creatinine, without which one would clearly be a little bit handicapped in making a very fair assessment of the pancreas.
Okay, so now this patient has undergone an imaging at a point in time, and it shows basically features of acute necrotizing pancreatitis. Swarup, as the CT radiologist here, just in a short 10 seconds, can you tell me what would be your features of acute necrotizing pancreatitis and what would you be talking about the peripancreatic in a succinct way, please?
Yeah. So basically, again, coming to the same thing, that we would identify the pancreas, the gland per se, and you would typically see swelling of the gland. At the same time, you would see necrosis, wherein you would see areas which appear much more darker, basically what is called as hypo-enhancing as compared to the gland itself. And typically less than 30 ounce field units on a CT scanner would tell us that definitely the parenchyma has shown necrosis. So sometimes you might just see very patchy necrosis within the gland. Sometimes you might be able to identify well-defined necrotic fluid collections within the gland. That is one. Secondly, you would be able to see peripancreatic abnormalities in the sense that you would be seeing peripancreatic inflammation, again, as I mentioned before, sometimes causing fat necrosis, which could happen in the surrounding the gland itself. You could see collections sometimes which are not organized at this point of time, but basically non-walled off collections, which typically would be seen going into all the recesses of the retroperitoneum. And at the same time, you could also be sometimes be able to identify vascular complications which can happen secondary to like a vascular thrombosis, which can happen secondary to the parenchymal necrosis itself. So abnormalities within the gland, surrounding the gland, and structures around the gland, typically most commonly the vascular structures.
Okay, so we know from the lectures that when you have necrotizing pancreatitis, the collections within the gland and outside the gland are called acute necrotizing collections. And ideally, you wait for about 3 to 4 weeks for them to begin to wall off. Now, Somil, we are following this patient for about 3 to 4 weeks now. The pancreatitis has evolved. Of course, clinically, we are monitoring the patient, but the radiologist tells you that there are walled off collections of areas of walled off necrosis within the gland and outside the gland. How would you take this forward in terms of the management?
So, so if the patient has a failure to thrive and is appearing septic in terms of raised white cell count, fever, CRP, or when I discuss it with you and you tell me that I am seeing some gas or some features of infection, definitely we would discuss and find out the best way to drain this collection. because that is fundamentally preventing the patient from progressing. It means there is an infection there, and that needs to be drained. One can give a reasonable trial of antibiotics, but not too long. One should just take so it's a risk benefit ratio. If it's a drainage which is possible, doable, liquefied, depending on how you would feel about intervening, one would discuss that and offer the patient that.
Okay. So again, from the radiologist point of view, Swarup, what would be the ideal thickness of the wall of a collection, which you need to mention on reporting? Just succinctly, what would be the thickness of the wall of the collection, which would be required to say that this you can do a percutaneous or an endoscopic drainage? Ideally, what would be the thickness?
Typically, a collection which is more than 4 millimeters or more in thickness would be a collection which will be easily doable for us to do a percutaneous drainage. Something which is thinner than that, the chances of for us to do a percutaneous drainage might not be really doable.
So that's a great answer. And one more question from the imaging point of view: do you require air within a collection to suggest that the collection is infected on imaging?
No. Presence of air would be a definitely confirmatory evidence that the collection is infected, but we do not always require the presence of air because you might not have gas producing organisms which could be causing it. So simple heterogeneity of the collection, wherein you would see a lot of areas of debris within it, or sometimes you might see hyper-attenuating the contents because of hemorrhage happening within the collection, or even simple infections itself can increase the density of the collection. These could all be an indicator of infection itself and not necessarily the presence of air.
Thank you. Shiv, I have a question to you. What would be your thoughts when you're assessing these patients for a apical drainage of these collections? Because many of the time these patients are in the ICU setting or in a setting in a ward where they may not be able to be sent down to the ERCT or to the floor CT scanner. So you'll have to do this as a bedside procedure. What would be your important points to look for when you're planning any kind of percutaneous drainages? Secondly, one more question is, if you are seeing air within a collection, does it always mean infection, or could you suspect something else also?
Answering the second part of question first, though presence of air can be indicative of infection, at times you can have a hollow viscous perforation or communication with the adjacent bowel. As we know, the pancreatic enzymes are lytic. They can easily burrow through the adjacent structure and cause the perforation. That can lead leakage of air, and air can be seen in the collection. So that can be another possible cause for the air. Talking about the first part, assessing the collection, there will be certain definitive things which we want to see. One is amount of collection. Second is the wall. Third is the accessibility on the ultrasound, because we know the ultrasound is helpful in the cases where the collection is more amenable, more easily seen. But the problem which happens with the some of the collections of the pancreatitis, they can be deep-seated and may not be easily accessible through the ultrasound guidance. So most of the time we can do it. Second thing, when we want to do, we try to assess the content of the collection. If collection has thin contents, small echoes, we know it can be easily done percutaneously. But if it has multiple septations, a lot of solid component, which is indicative of organized sludge, this may not be easily amenable to the percutaneous drainage because the catheter sizes which we commonly use may not drain it completely. In that case, this whole findings and the scenario which we'll discuss back to the clinician and will decide unanimously which is the preferred route. And if it is doable on ultrasound, we'll do it. If it's not, then CT will be the best modality to do in cases where the ultrasound is not feasible.
Thanks, Shiv. Somil, what is the one point or the couple of points which will push you towards an endoscopic drainage or a surgical drainage or a radiological or an image guiding drainage?
Yeah, I think it's the proximity of the collection on fluid accumulation to a hollow viscous, particularly the stomach, which can be accessed through the endoscope. So if it is sitting on the lesser sac, abutting the posterior wall of the stomach, and the endoscope can straight through go in, and the endoscopist looking at the images is confident that he could get this out through EUS. That is one thing. CT drainage, of course, also is a preferred thing, where if you get a good window between the spleen and the colon, or the spleen and the kidney to access it, then you could do it in a staged procedure and drain this out. Generally, we would say surgical drainage is the last resort, because of, obviously, if you have two modalities giving you the same outcome with a lesser morbidity, then you would choose that first. But there are cases where none of the above two are possible, then you would preferably try to do it through a surgical approach through the flank, or a laparoscopic, or a frankly open surgery, which which would be required still in 20% of patients with pancreatic necrosis.
So that's a very important point from all the three panelists, that you can use imaging to drain the abscesses. You could use endoscopic techniques, and in the worst case scenario, if either of the two are not possible, surgical techniques for evacuation of these collections, necrosectomies, is also required in probably 1/4 or 1/5 of the patients in the current day and age. The last case scenario, which I just want to add on to this, because it's a complicated case of acute necrotizing pancreatitis, is Somil, the patient is in a couple of days after being stabilized following drainage. The patient suddenly has a critical event and codes where you see the patient actually dropping his BP, developing tachycardia, looking very uncomfortable, and the immediate lab investigation shows a drastic drop in the hemoglobin, which was about 9 or 10, and it's gone to about 6. Now, what are your thought processes at this point in time, and what would be the imaging choice of investigation you would do now?
Yeah, so I would clearly suspect a hemorrhage within an infected collection, either per primum from the infected necrosis or an underlying pseudoaneurysm. I think if there is an indwelling drainage tube which has been put and there is frank blood in the tube, I would shift this patient straight away for a formal angiography with an intention to embolize and do whatever is necessary. If I don't see any blood and the patient is unstable, I would ask for a CT scan with an angiography, CT angio in the first instance.
So that's a great point to take home, that if a patient who was relatively stable suddenly decompensates, bleeds, you have to suspect an internal source. And because there are pancreatic enzymes surrounding the vessels, the three common vessels which tend to get eroded are the gastroduodenal artery, the splenic artery, and occasionally you will have a common hepatic artery getting involved in these processes. So both Shiv and Swarup can take this question in sequential order, because I know that each of them tend to work in terms of tandem approach. So Shiv, what you can even share the slide which you showed in that case of a pseudoaneurysm. If you have it ready with you, you can show the delegates what exactly is a pseudoaneurysm briefly, and tell them what would be the next one. And then Swarup, you could show the same in terms of your case. Shiv.
Yes, sir.
Excuse me, sir.
Yes.
Sir, we are short of the time, please.
Okay, so another just about 30 seconds more. We'll quickly finish this and then move to the sessions. Okay.
So
yeah.
We'll skip the slide, sir. It will take time for loading.
Yeah. Just quickly, just state your findings. Shiv?
Yeah, sir, it is taking time to load.
No, just tell the findings. That should be enough.
Yeah. We'll see the focal dilatation, which is indicative of aneurysm, and put a color. We'll see the sign which I had shown, which is commonly called a Pepsi-Cola sign or a yin-yang sign, which is indicative of pseudoaneurysm. And additionally, we'll try to see evidence of any hematoma.
Okay, perfect. So Swarup, I think your findings will be more or less the same.
Yes.
And you will be just able to map the vessels very well. So I think we'll just close the session now. Thank you to all three of you all. So, and we've kind of shown three case scenarios, which will be very interesting on a day-to-day practice. And what it just shows you that you require a multidisciplinary approach with surgeons, gastroenterologists, radiologists, intervention radiologists to manage patients of acute pancreatitis and its complications. So I think without further ado, I'll just share my screen and I'll take my session on the imaging of CA pancreas. Just give me a second, please. Thank you, everybody else. Okay, am I audible, Dr. Mehta?
So you are audible, sir.
Yeah, I'll just share my screen right now. 1 second. Visible for everybody?
Yes, yes.
Yes, it is visible.
Okay, so I'll just start it off. So after the series of 3 lectures on pancreatitis, I just want to bring this short but succinct lecture on pancreatic adenoCA because it's a major concern both to the clinical as well as the radiology fraternity in terms of its presentations and its mimics of acute pancreatitis or even chronic pancreatitis. So this is a case which we had over the last 6 months evolving with us at our institution. The 60-year-old lady who had epigastric pain radiating to the back since the month of June 21. The pain was fluctuating, was there for about 4 to 5 weeks, and she had no other constitutional symptoms. She landed up with a gastroenterologist colleague of ours, and when we were investigating this patient, the laboratory showed a combination of hyperamylasemia, elevated lipase. The amylase levels were about 3x the normal levels. The patient had diabetes, and the clinical diagnosis was probably recurrent pancreatitis or chronic pancreatitis, and an MRCP investigation was asked for this patient. So the scan was done, sorry, it's not 22, it's 22nd of July. And what you see, and I'll just show you what exactly are we seeing. So this is a normal looking gland. So whatever is marked in the green arrows is a normal looking gland on these oblique sections. What else do we see? Along with the normal looking gland, what we saw was there were 2 ducts draining the pancreas. So as my previous colleagues mentioned, when you have 2 differential ducts draining different portion of the pancreas, we call that a developmental ductal anomaly or a divism. There are numerous types of the divism, but in this patient, it was a pancreatism, and the entire body and tail of pancreas, sparing the head and the uncinate, was drained by the minor duct called the duct of Santorini into the minor papilla, not into the major papilla. So normally the pancreatic duct drains with the common bile duct and the major papilla, but in this case, the patient had a pancreas divisum where the bulk of the pancreas was draining into the minor papilla. Now, when you have such kind of a ductal variation, you don't get the standard appearances of acute pancreatitis or recurrent pancreatitis because of the anomalous ductal drainage. And what you will get is focal areas of pancreatitis involving only certain portions of the gland. Now, if there is only involvement of the duct of Santorini drainage, it will be body and tail pancreatitis. If it's involvement of what we call the duct of Versum, you can get focal pancreatitis involved or the unmet process of pancreas. So in this case, what we noted was that the body and tail were normal. You had a developmental anomaly, but there was a focal swelling of the pancreatic, the posterior or the dorsal aspect of the pancreatic head and the uncinate process. And if you note very carefully, the gland doesn't look normal. It looks slightly brighter. And there's a lot of fat stranding surrounding the duct itself out here, or the gland itself. So when we look at this and the clinical dogma, the patient was having symptoms of pain. We thought that this is going to be a focal pancreatitis. There's been recent exacerbation, and that's what we actually assessed the patient for. And we gave the diagnosis, and the patient was managed for the same. What happened to the patient over a period of time? I'll just continue. Give me a second. You can see that mass-like inflammation there. So we did certain more imaging sections or imaging sequences, as Swarup mentioned in his talk. And you could see that focal area of abnormality involving the dorsal aspect of the head and the uncinate process of the pancreas. What happened to the patient was the patient was lost to follow up to a hospital, but came back to us in the month of January this year, around the second week of January, saying that the symptoms had worsened. And what were the symptoms? The symptoms were primarily significant increase in the intensity and the duration of pain. The pain was radiating, typically going back to the spine area and the lower thoracic girdle, and was not responding to the analgesic since the last couple of months. So there was a change in the symptomatology of the patient, and this was a significant concern. What we noted on imaging, to our surprise, was that lesion which was seen on the prior imaging about 7 months back, involving the head and the uncinate process, had substantially increased in size. Not only had it increased in size, it had gone outside the pancreas. You can see that it's kind of gone and caught the vessels. The red arrow shows the mass, and you can see the area of contact with what we call the superior mesenteric artery. Now, what was the cause of the pain? The pain was because there are numerous neural pathways or nerves which tend to go along these vascular channels or these vascular structures. If the disease process, whatever you're looking at it, whether it's pancreatitis or pancreatic CA more often, they tend to catch these nerves along these vessels. And when it tends to catch these nerves, you tend to get chronic intractable pain. Now, this pain usually does not go down with painkillers, and you need drugs which are in the category of morphine kind of Schedule H drugs to reduce or ameliorate these pains. So the pain change itself had made us very worried. And when we saw this imaging, we were extremely concerned whether there was an underlying mass lesion which was actually causing the pancreatitis, which was the earlier presentation, but now the increase in size of that lesion made us extremely worried. At the same point in time, we evaluated the entire abdomen and pelvis, and to our horror, what we saw was multiple lesions in the liver. You can see them in the right lobe of liver. This is a cyst sitting up here, but all the lesions marked with the red arrows represent focal observations or focal lesions, which are very, very suspicious for metastases. There's a particular imaging sign called the targetoid morphology, which kind of tells you that these are highly suspicious. So once we had this on CT, the patient was actually coming in for an MRI of the lumbar spine because of the backache which she was suffering. We did not do that scan, and we instead got a PET CT done for the patient. Now here, this is not an imaging which you commonly seen, and you're not seen in the prior lectures, but PET CT is a very important modality, especially when you're assessing for pancreatic neoplasms or the possibility of a pancreatic neoplasm in an overlying case of pancreatitis like what we had. The PET CT kind of injects, during the PET CT, you inject something called FDG, which is fluorodeoxyglucose. It's a variant of glucose, and any tissue which is very rapidly multiplying, mitotic, like what you would see with cancer, will take a lot of FDG. So here in this case, you could see that focal area of uptake of FDG, which is standing out as a hot area in the pancreatic uncinate, and you could of course see the same thing in the liver lesions as well. And this kind of proved our thought process. Now that focal pancreatitis, which you had seen in the month of June 21, was actually caused by an underlying neoplasm, which was masked by the inflammation, which had grown in size in the next 6 months and had also developed liver metastases. Now, what we also do in our institution is not just the diagnostic yield of it, but we also have the so-called therapeutic or quasi-therapeutic forms of biopsies, diagnostic biopsies, aspirations, ablations, and so on and so forth. At our place, so what we did in this case is that we did a needle-guided percutaneous biopsy of the segment 7 lesion, and the biopsy findings showed that this was a metastatic adenocarcinoma arising from a primary pancreatic neoplasm. So why have I started with this case is to show you that the first 3 lectures primarily focused on the impact of pancreatitis in terms of its morbidity, its mortality, the role of clinical pathology and radiology. But very often we see this condition, which is pancreatic ductal adenocarcinoma or PDAC, mimicking pancreatitis, and it can happen to anybody. And in your day-to-day practice, this can have a significant impact in the way you practice your clinical medicine. So this is a classical presentation of pancreatic ductal adenocarcinoma mimicking as focal acute pancreatitis or focal recurrent pancreatitis. So what are the diagnostic conundrums in this case? Now, this is very important for the participating delegates in this because you tend to get a lot of overlap in symptomatology. In this patient, the patient's age was 62. So when you look at patient age and onset of symptoms, typically pancreatitis is a disorder of young, or you would say middle-aged individuals in the range of about 18 to about 45, 50. Once you start developing symptoms mimicking pancreatitis, typically beyond the 5th decade of life, you need to be careful that you need to follow up these patients. So therefore, when Saumil mentioned to you in that 44-year-old man that he would follow the patient up probably at about 4 to 6 weeks is for the same reason that you don't want to miss an underlying pathology causing pancreatitis. So you don't want to miss either a biliary pathology or a pancreatic adeno-CA. The second thing, which was a red herring in this case, or a red flag in this case, was the persistent pain, which was now not responding to treatment. And it meant that the perineural pathways around the gland were involved. And that was something which was a red flag, which needed to be raised, and we could have brought this patient in slightly earlier itself. Diabetes mellitus, late onset diabetes, typically in the 4th, 5th, 6th decade, 7th, and so on, should always raise the possibility of an underlying cancer sitting in the pancreas, which is actually causing destruction of the exocrine function or the endocrine function, and therefore causing the patient to present with diabetes. So late onset diabetes is of concern. Yes, you can get diabetes in patients with chronic pancreatitis as well, but that would be over a period of time. Pancreatic adenocarcinoma does not give you that much of time to develop this symptomatology. Coexistent ductal anomalies. Now, in our case, we had a patient with a pancreatic developmental anomaly in the form of a divism, and that kind of clouded our diagnosis or giving the accurate diagnosis, because when you have a coexistent anomaly, you know that patient is of a higher likelihood to develop pancreatitis, and you are not going to think straight away of a pancreatic adenocarcinoma. But this is something to remember, that all pathologies can coexist with each other. Laboratory markers. Elevated amylase and lipase, though sensitive to a particular diagnosis, are not specific to the etiology. So you can get pancreatitis, but the underlying cause of pancreatitis could be something totally different. It could not be a benign, it could be a malignant pancreatitis where you have a PDAC causing the pancreatitis. So this is a major diagnostic conundrum. High sensitivity, but low specificity to a particular diagnosis. And lastly, the imaging features are not always typical or sine qua non of pancreatitis or of PDAC, and there could be an overlap. And because of this overlap, you tend to face a lot of issues. So from a standpoint of view, from a general practitioner or a clinician, when you're looking at the patient the first time, what do you need to really worry about when you look at these patients? Always carefully assess the clinical presentation, the duration, the association with risk factors. Now, risk factors could be obesity, you could have diabetes, you could have patients with hypercalcemias, patients who tend to have alcohol abuse over a long period of time. And typically in patients with alcohol abuse with recurrent pain, usually you have about 2 years when you have these symptomatologies to get the diagnosis of chronic pancreatitis. So clinical presentation and risk factors are absolutely important. And the combination of the imaging laboratory findings put together along with this will allow you to minimize the quantum of overlap. Otherwise, you're going to get a substantial overlap in these cases. Now, look at this. About 1.8 to 4% of patients who have chronic pancreatitis have the potential chance to have an underlying pancreatic adenocarcinoma. So the symptomatology will be the same. The laboratory findings could be the same. The imaging could have substantial overlap. So you could have both conditions coexisting with each other, and you may not be able to diagnose till there is metastatic disease or there any nodal disease or liver mets like we had in our case sitting up here. Tumor markers. So this is an important question which physicians will ask. Will tumor markers help? And the tumor marker which is typically seen in patients with pancreatic cancers are CA19-9. Ideally speaking, a CA19-9, usually about 40 units per ml, has got a high specificity for the diagnosis. However, the sensitivity of this tool is not as high as a specificity. So you cannot exclude the diagnosis of malignancy just because the CA19-9 levels are not elevated. One more problem with this is all tumors are not secretory. A good number of tumors may be non-secretory, or they may have a very low potential for secretion, so they may not get elevated. The tumor marker may not get elevated very early in the disease unless the patient starts developing metastases to other locations. In our patient, the initial CA19-9 done in the month of June 21 was normal, but the CA19-9 done around this month of January was in the range of about 39,000, which was pretty much definitive of a PDAC with metastases. What are the imaging dilemmas? Imaging dilemma is very important. Acute pancreatitis generally does not cause that much of a conundrum, but it is the focal or the chronic pancreatitis which causes significant impact on the radiologist's mind when they used to give the diagnosis of pancreatitis or is it PDAC. And there was one of the questions which were asked in the previous by one of the delegates about autoimmune pancreatitis. Autoimmune pancreatitis, especially in the focal form, is a major diagnostic dilemma, but to differentiate this from a pancreatic adenocarcinoma. Other common forms which we commonly do see on imaging are mass-forming pancreatitis, also paraduodenal pancreatitis, also called as groove pancreatitis. It typically occurs between the pancreatic head and the second and third portion of duodenum. We do see that in clinical practice, but you have to have a high index of suspicion for this condition and not miss a PDAC sitting up over there. Lastly, obstructive pancreatitis. This term is important because we always associate ductal dilatation, especially if it's disproportionate for the amount of glandular changes in terms of a potential PDAC. But in a good number of patients, you can get this to be due to primary chronic pancreatitis. We call this terminology obstructive CP and not a PDAC. Very, very important to remember. Even the imaging signs can overlap substantially, and I'm not going to dwell too much into it, but please remember that if you 100 patients with pancreatic head cancers, only about 80% of them will have ductal dilatation. The remaining 20 may not have ductal dilatation, and the number is even more when you're looking at body cancers, where only about 50% of pancreatic adenoCAs of the body tend to have ductal dilatation. There are certain findings which can help you towards the diagnosis, especially if you're looking at the vascular structure surrounding it. But yes, there is some degree of overlap, especially when you're looking at mass-forming chronic pancreatitis, because they can mimic PDAC per se. Lastly, biopsy. Now, this is an important thing to remember, because how do we prove the diagnosis of pancreatic cancer? Now, there are different ways to prove it, very much similar in how you kind of tackle pancreatitis. So when you're having pancreatic adenoCA, there are different ways to put the needle into the pancreatic tissue to get the diagnosis. One of the ways is to do it CT guided. It could be done either in a supine or in a prone position, depending on the accessibility. Ideally, you don't use ultrasound to biopsy the pancreatic mass because of the limited visibility of the gland. So CT is the modality from the imaging spectrum. But then you have endoscopists who have developed endoscopic ultrasound techniques, which can allow you to get to a particular pancreatic lesion, especially along the third portion of duodenum, the second, third, or the periampullary region, and easily access that as compared to radiologists. Because of the large amount of vessels surrounding the pancreas, you have a potential bleeder. But even with all these techniques, you can see that the specificity to the diagnosis is not always too high, and there could be significant overlap. Now, for example, if you were to do in one series which was published of late, if you were to do about 100 biopsies of the pancreas in suspected cases of pancreatic adenoCA, the false negative biopsy rate could be as high as 60%. So the tissue yield is not ideal. And therefore, what I'm trying to say is that as clinicians sitting out here, as delegates out here, have a kind of a multimodality or a multidisciplinary approach to choose the optimum imaging or intervention technique to get the diagnosis. There are surgical dilemmas also. If you were to operate them and you would provide a Whipple's procedure, what would happen is about 5 to 35% of these patients are going to turn out to have non-neoplastic conditions, primarily chronic pancreatitis. So that's something which you need to look for carefully. So I'll briefly talk about CA pancreas in the next about 10 minutes. And I'll say that typically it's about the fourth leading cause of cancer in the Western population. In the Indian population, it's not as high. There are other malignancies which tend to come over. There are increased potential risks, especially if you're looking at chronic pancreatitis, diabetes, smoking to some extent. There is a syndromic association, so there could be a familial component to this itself. From an imaging point of view, what we really need to know is, and what is the information we need to give the surgeon, somebody like Saumil out here, is what is the resection margin, what is the lymph node involvement, and there you have a pathological term called lymph node ratio. Look for neural involvement, and of course, the operative factors like aberrant artery, which is coming in close proximity to the tumor, which is going to affect management. If you're looking at the role of imaging, the role of imaging is multi-factor, or it has got a multi-pronged approach. It's going to be using in detection. It can be used in staging, biopsy, treatment planning. It's very important whether it's surgical or non-surgical, and of course, post-treatment assessment. Now, detection, you've already heard using ultrasound, CT, or MR, MRCP. MR could be with or without contrast. Staging ideally is done with a multiphasic pancreatic protocol. You would use MR if you're having a conundrum about the biliary tree or the presence of liver mets. PET-CT is good, especially if you're staging the tumors with locally advanced tumors which are unresectable tumors, because these patients will go for neoadjuvant chemotherapy and then they will get downstage. And then whether they're going to see whether there's any treatment assessment response, you would do a repeat PET CT about 3 or 6 weeks or 3 or 6 cycles post the chemotherapy to assess risk response. From a radiological point of view, our job is very limited in terms of what we need to do. We're very focused, and that's what we need to assess in terms of vascular relationship, perineural spread, nodal disease, and organ involvement per se. So as my colleague Swarup said, that CT is the way to go for pancreas. So this is a classic multiphasic CT, which you should ask for. So whenever you're sending patients for imaging, ask for a multiphasic CT, and that would be very important. Ideally, you want to assess the tumors in the pancreatic parenchymal phase. You don't want to assess it later than normal. And that's the crux to evaluating these patients. That's because pancreatic tumors tend to be hypo-enhancing as rest of the gland, and you would be able to easily identify the tumors. Why do we use CT? It gives great vascular landmarks. So here you can see the superior mesenteric vein and the artery in the mesenteric root. It gives you a lot of information on the perineural structure. So here you have the celiac ganglia, which is beautifully seen on CT. You have the hepatic plexus going along the common hepatic artery. And of course, you have the mesenteric venous plexus, combination of the aortic plexus. They're all important structures where the information needs to go to the surgeon by and large. This panel kind of shows a typical pancreatic head tumor. And you can see the lesion sitting up with the red arrow on the top left panel, and the additional findings which are seen in the form of an infiltrative nature of the tumor, the ductal cutoff with pancreatic glandular atrophy, which is seen in the body and tail, and of course the peripancreatic inflammation, infiltration, which is very important. It's very, very uncommon for you to see tumors which are small. It's usually picked up as an incidentaloma, and here's a classic tumor which is less than 2 centimeters. There's no vascular involvement, no nodal disease. So this patient goes up front straight for surgery. A larger tumor greater than 2 centimeters, usually it means it has gone outside the gland, and therefore the radiologist's role becomes very, very critical to assess the vascular structures. You need to see if there's any contact or there is any amount of encasement or infiltration of these vascular structures, but still these patients are amenable for upfront surgery. As soon as the tumors become larger, ideally more than 2 centimeters, they go outside the gland. They start playing around with the vessels around there. They may either contact them or they may invade them. And these tumors tend to get managed differently based on the NCCN criteria, either as borderline resectable tumor. This is the guideline itself. I won't be spending time on that guideline, but it's here where the radiologist really, you get the money for the kind of work which you tend to do. Vascular landmarks, identify whether the tumor is borderline resectable, or if there is a lot of vascular encasement, do we have to go in and this is no longer a resectable tumor? So I'm going to show you a bunch of cases where the tumor is resectable. So if the superior mesenteric vein is encased for less than 2 centimeters in length for a primary head neoplasm, but the artery is free, the superior mesenteric or the celiac trunk, Sawmill as a surgeon will say, yes, I can reconstruct the vein. This is a borderline resectable tumor, and I might want to give this patient a chance with an upfront Whipple surgery. At the same time, when you have a large tumor like here, which is invading across the splenic vein with what we call tumor in vein, which has gone all the way up to the portal vein, this means this patient is not resectable, and imaging plays a vital role in identifying these. Arterial involvement is a complete no-no for any kind of involvement, especially if you're looking at common hepatic artery or celiac trunk involvement. Change in caliber, again, a very important feature for unresectability. But more importantly, what I'm going to focus on for the next few minutes is neural invasion. And I'll just show you a couple of cases where CT is great in identifying tumor going along the vascular channels. All these are very important because if you have neural involvement and vascular involvement, the chances that this patient is going to have upfront surgery are very low. The chances that this patient is going to have recurrence following any kind of management is very high, and therefore the overall disease-free survival is lower and the overall survival of the patient is very, very low. Most patients present to us in advanced states like what we have here on the right panel, where there's a lot of vascular and perineural involvement, and 2-year survival rates, or let alone 5-year survival rates, are extremely dismal. They're about single-digit survival rates because of the high potential chance for recurrence in these patients. So here are a battery of cases which show vascular involvement and therefore perineural involvement. Of course, this is classic hepatic metastases. So what I'll do is, if I were to just show you what is the role of imaging, kind of succinctly summarize it in the next minute or so, it is basically to detect, to help the surgeon and the gastroenterologist stage the disease accurately. You use CT, MR, PET CT, a combination of those. Talk about vascular, nodal, perineural, and organ involvement. Try to find a way to biopsy this either by CT or endoscopic techniques. If you have metastatic disease, it's better to hit the metastases than the primary disease because of the complications associated with the deep-seated nature of pancreatic tumor. Allow in the patient management, whether this is resectable or non-resectable. If it's non-resectable, does the patient go for NACT or immuno or radiation therapy? And then, of course, follow these patients post-treatment to see whether there's any response or there is disease progression using a combination of CT or PET CT. We would prefer PET CT in all these patients. Thank you so much for a patient hearing. Dr. Chitesh, over to you.
Thank you very much.
Yeah.
Thank you, sir. Sir, there is one question.
Yes.
What is the role of surgery in CA head of the pancreas?
I think that question would be better answered by Somil rather than me, because he's a surgical colleague out here. Yeah.
Okay.
Somil, can you answer that question, please?
Yeah. So I think surgery is the cornerstone of treating head pancreas and pancreatic cancer. Of course, only 20% of patients would be eligible for surgery, and there are methods to make patients convert from initially inoperable stage to operable through chemotherapy, neoadjuvant, etc. But a well-performed surgery with a low complication rate and a complete R0 clearance does achieve good survival rates of up to about 40% at the end of 5 years, which is as good as it gets for a inherently poor biology tumor like a pancreas cancer.
Okay, Somil, I think you can take your session next, because I think we are running slightly short of time.
So I will
finish yours and we'll wrap it up after that.
Yeah,
thanks.
So I will go through quickly. I assume my screen is visible.
It is.
Yes.
Yeah, I'll just start the slideshow. Okay, so I'll just run through pancreatic tumors. Dr. Karthik Ganeshan has explicitly laid down the foundations for imaging, and he has brilliantly explained what kind of tumors and classification we have. So I would just basically stage my talk as the basics. How do we treat, and how do we go about adjuvant and neoadjuvant treatment? So we are familiar with all the patients, all the tumors which can cause jaundice, right from within the liver up to the ampulla and the pancreatic area. And pancreatic cancer essentially is one of the commonest causes of obstructive jaundice. And the principle essentially for treating obstructive jaundice is that you bring the bile back to the bowel, which means that either whether you treat it with a curative intent or with a palliative intent, the idea is that you basically bring the bile back to the bowel and take away the jaundice. Now, pancreas cancer, Karthik has already said, it's an increasingly common diagnosis. We're seeing more and more patients with young populations being affected. It has a significant overlap with chronic pancreatitis. And apart from the cancer itself, it can cause severe systemic disturbances in the form of jaundice, cholangitis, vascular involvement can cause portal hypertension, etc. And these are the 4 major types of cancers that we deal with: adenocarcinoma, cystic lesions of the pancreas, which are potentially malignant. There is a group of neuroendocrine tumors, and there is a miscellaneous group, which are rare tumors, which I think are beyond the scope of discussion today. So it's a common cause, 4th leading cause of cancer-associated mortality. But among all these demographic features, what I want to say is that since the past 2 to 3 decades, the mortality and the morbidity and the outcomes, the oncological outcomes with pancreatic cancer have not changed. Almost every other solid tumor has improved its performance in terms of survival, in terms of effective treatment. But essentially, pancreas cancer has remained where it is. I think this is the most important takeaway today, that regardless of the advances made, pancreas cancer in terms of its outcome has not really made substantial improvement. So the 5-year overall survival for all comers essentially remains at 5%. Only 20% of patients would be amenable for a resection. And after resection, you're looking at 5-year survival rates of 20 to 25% or a little bit more. There is a well-defined biology to understand evolution of pancreatic cancer, but unlike colonic polyps, where you can actually look at it through surveillance endoscopy to understand pancreatic intraepithelial neoplasia, what we call as PANIN, there is no method. I mean, how can you really look at this transition from in situ to an invasive cancer? So essentially, this is more academic than a practical utility. And when you actually look at pancreatic tumors, you find that only 15 to 20% are resectable. Almost 1 in 2 patients will have metastases at initial presentation. And almost 1/3 of all patients will be beyond the point where they can ever qualify for an operation. Now, so this is the spectrum of the cancers that we see. You have a clearly resectable patient where you clearly can do a straight operation and take the cancer out and achieve the best shot at cure. There is a group of patients, what we call as borderline resectable, meaning they are not clearly resectable, but not unresectable either. And you can convert them into making them operable or resectable by giving the correct chemotherapy upfront. There is a group of patients which is not metastatic, but is clearly spread out locally so badly, involving the vessels or adjacent structures, that it can never ever be converted into becoming operable. And there is clearly the last stage, which is the metastatic stage, where the cancer has spread well into the lungs, liver, bones, etc., and is beyond the point of being offered any curative treatment. As Karthik has said, CT scanning is the most important thing, that you help the surgeon to decide whether you can operate or not. So in that sense, the radiologist stages out the disease for us locally and systemically. And because this is ultimately the fundamental step which will decide as to how well a patient is going to do. He's already described the pancreatic protocol scan for you. And these are some of the numbers that we look. I think there was a question as to does pancreatic cancer surgery help? Yes, this is as good as it gets. This is for all comers. And mind you, we are just looking at pancreatic head cancers who go through Whipple's. We are not looking at the periampullary, distal bile duct cancers, duodenal cancers, which have a slightly better prognosis. So this is a very, very select group of patients who goes through a pancreatic or duodenectomy, which can of course be performed for a vast number of other conditions. Presenting features, I won't go through it, but vague abdominal pain, weight loss, dyspepsia, jaundice, pancreatitis, onset of fresh diabetes, or if a person is diabetic, you start losing control over it. These are some of the things how patients are likely to present. And this is a typical CT picture where you see a classical double duct sign with a dilated bile duct, dilated pancreatic duct, a mass occluding the junction of the union of the bile and the pancreatic duct in the background of an elevated CA19-9. And of course, you can have situations where you have a larger tumor sitting there and can be responsible for mimicking pancreatic cancer. These are the periampullary cancers, as we call it. But essentially, we look at all of them as a single unit because imaging-wise and treatment-wise, the approach remains the same. Almost 60 to 75% of all of these cancers would happen within the pancreatic head, 15 to 25% in the body, and the rest in the tail. And surgery is the only treatment. There are a lot of major blood vessels which run behind and through the pancreas in close proximity to the pancreas. And this is where a very good CT scanner with a dedicated radiologist who can interpret it from the clinician's point of view becomes important to identify the vascular involvement and map out the disease so that the surgeon can actually plan out the operation. So the importance of CT scan is not just for diagnosis, it is not just for staging, but it is also providing a roadmap to the surgeon to do a good operation, which definitely will then increase the safety for the patient. We've discussed about scanning. Chest CT scan can be substituted for a routine PET scan. I have written routine PET scans not required, but this is more when you look at the entire world population. Where available, it should be done. It is a desirable indication, and it definitely helps to understand the spread of disease, especially when you have elevated tumor markers and you have a loco-regionally advanced disease. Certain units in the world regularly perform a staging laparoscopy, especially if you're planning neoadjuvant treatment or you find that the tumor is beyond 3 centimeters in the primary dimension, because this helps to understand whether it's metastatic or not. And this is in a nutshell what you and this is likely to change the management in 15% of the cases. So if you took 100 patients with pancreatic cancer, performed a laparoscopy, there's a chance that you will change the stage, you will upstage the disease in 15% of the patients. Karthik has already mentioned about the biopsy. Should we go for a tissue diagnosis? Not always. I think if the radiology is unequivocally positive, you are not planning neoadjuvant treatment, then you don't need a tissue diagnosis, because you basically are just going to spend extra time, get a false negative result in 60% of the patient and not change the ultimate this thing. CT scan in terms of protocol, Karthik has explained, and this is again another closer depiction of why we need a very nice CT scan to understand the anatomy. So this is the kind of borderline resectability that a CT, we would expect a radiologist to tell us. The tumor could be close to the vein and the artery and the celiac axis, and we actually want to describe the relationship in terms of its proximity and how much it abuts in a very, very detailed manner. So you could have a complete circumferential encasement of the superior mesenteric artery, more than 180 degrees or less than 180 degrees. And this helps to classify the tumor into borderline resectable versus locally advanced, and at the same time helps to understand if the patient will ever go through an operation or not. So if you have an arterial tumor contact which is limited, you could still think of shaving it off the artery. But when you have more than 180 degrees, clearly this becomes inoperable, because arterial replacement has an extremely high risk surgery with no oncological benefits. I think a similar thing with the portal vein and the superior mesenteric vein. You define the relationship of the tumor to the portal and the superior mesenteric vein, and then one can decide the need for a vascular or a venous reconstruction, and map it out and be prepared with the appropriate grafts or the appropriate extended surgical procedure that is required, rather than having a surprise on the operating table. Should you do an ERCP? Yes, I mean, there is a defined role for ERCP, mainly to clear off the jaundice before an operation. Is it always required? Again, not necessary. You could do it in very select situations. You don't need to relieve the jaundice in every case. But where there is a diagnostic dilemma where you can't differentiate between a benign or malignant stricture, the ERCP and an EUS helps out in getting tissue sampling. It could help to relieve the jaundice. And especially if the patient has got cholangitis, it helps in draining the bile duct and relieving the cholangitis. So should you stent a patient before sending off this patient for a Whipple's operation? The real indication would only be jaundice and cholangitis. You don't need to stent every patient, because it just adds to the time. There are complications associated with the stenting itself, and it just delays the definitive procedure. So if you have a high bilirubin, long-standing jaundice, a patient is nutritionally poor, has got medical comorbidities, and has got cholangitis, and for some reason you need to plan neoadjuvant treatment, you need to take the jaundice out, then endoscopic biliary stenting or percutaneous biliary stenting, where endoscopy is not possible, should be done. There are complications of stenting itself. It increases the risk of surgical infection and problems. Therefore, now stenting was highly proposed in the early 2000s, but since the last 10 years, this has really gone out of vogue. There are randomized trials to prove that where possible, stenting should be avoided. Should you get a pre-op biopsy before doing an operation? Not necessary, unless there is a diagnostic doubt and your biopsy can change your management. Like, for example, you're dealing with autoimmune pancreatitis or a pancreatitis or a lymphoma. In that case, a biopsy can definitely be required. But where there is a clear-cut lesion, PET positive, elevated tumor markers, double duct sign, obstructive jaundice, you should not go chasing for achieving a biopsy, because it doesn't change your management, and the risk of false negative biopsies is high. Of course, if you want to treat it with palliative intent, or you want to start neoadjuvant treatment, the risk of the use for biopsy will come. And I suspect that over a period of time, the radiologists will have to do more biopsies, because there is an increasing role for neoadjuvant treatment in pancreatic cancers. So again, as I said, if you do carry out an operation, what is the chance that you're going to hit on a benign lesion? The chance is 5 to 15%. And if you were doing 100 pancreatic resections for pancreatitis, proven pancreatitis, there is still a 10% chance that out of those patients with pancreatitis, 10% will harbor an underlying cancer. So this is exactly why you should not keep on biopsying and avoid a biopsy unless there is an indication for the same. Two main operations are described. You could have either a Whipple's procedure, pancreatic or duodenectomy, a highly complex procedure, I think, with or without a vascular reconstruction. And of course, if you're taking out the left half of the pancreas, depending on the location of the tumor, you could either do what we call as a distal pancreatectomy or a subtotal pancreatectomy, depending on the location of the tumor. This is a specimen of a Whipple's operation that has been done for intraductal papillary mucinous neoplasm of the main duct. I'll come to that a little later. But after you take it out, basically the grade of the tumor, R0 resection, and the size of the tumor, these all will determine as to how well you're going to do in the long term. Is it a safe operation? Well, in high-risk series, the chance of having a significant complication, a life-threatening complication, is about 3%. The main complication being a pancreatic fistula, which takes time to heal, which can be there in up to about 1 in 5 patients. And this, of course, depends that if you have a soft pancreas, a very small duct, sometimes pre-existing pancreatitis, things become a little difficult and you could have an incidence of complication. But this is exactly where you require a good radiologist and a dedicated team of pancreatic surgeons who has been trained to do the operation to carry out these high-risk operations. I would just, sometimes you can't take the tumor out because it is just badly stuck to the vessels and you end up doing a palliative bypass. This operation is more or less obsolete because if you again map out your anatomy and stage the tumor correctly, the same procedure could be achieved through an endoscopic or a percutaneous biliary stenting with a metal stent that relieves the jaundice. And you could also have a duodenal stent to take away the duodenal outlet obstruction as a palliative procedure. Now, this is some of the data. How are you going to do after the resection? If you have a node negative tumor, your 5-year survival is 30%. If you have a node positive tumor, your 5-year survival is 10%, which clearly means that in spite of doing a good operation, you still are lacking something to improve the survival. And this is where you come to basically the role of adjuvant chemotherapy. So initially chemotherapy was not given, but then people felt that in spite of doing a good operation, if patients don't survive longer, we need to attack the biology of the tumor. And therefore, every patient with a resection, regardless of the size, regardless of the grade, now would qualify for chemotherapy. There are enough trials now, the SPAC trial, the Prodigy trial, where you could use either gemcitabine, capecitabine, or nab-paclitaxel to basically give adjuvant treatment. And there are proponents where you can even give adjuvant chemoradiation, which is a practice which is developing quite significantly in the United States. The Europeans and the rest of the world tend to give only chemotherapy, and it does have a 33% survival benefit. So this is a flow chart of how you would actually deal with patients with pancreatic cancer who are locally advanced, give them chemotherapy, make the tumor smaller, and reassess at imaging. And again, here I would like to say that it is extremely quite challenging for radiologists to stage scans on patients who had previous chemotherapy. I think it's a great challenge to differentiate between active tumor versus chemo-induced fibrosis, what we call desmoplasia. And this is where, again, expert radiologists with a dedicated interest like our team are required to understand the stage of the disease and plan help in further management. What are the response rates after chemotherapy? We are looking at almost 30 to 40% response rates on patients after chemotherapy to help us to downstage the disease and make, so 1 in 3 patients who was initially inoperable is likely to qualify for an operation. I would just run through some final slides. This is a clear example of a cystic lesion in the pancreas. The immediate indication would be that this is a pseudocyst. But when you look at this more closely, there is a solid element within the cyst, and this patient actually had a cystic cancer of the pancreas. This is again something that the radiologist needs to see and tell us with great deal of accuracy. This was the resected specimen where we took out the complete cystic lesion for a cystic cancer in the pancreas. This is similarly another large lesion in the pancreas with a large cystic solid element. You can see it is actually abutting the takeoff of the celiac artery. And in this particular case, Karthik very nicely did a 3-dimensional venous and arterial reconstruction for me to plan out the operation. He actually mapped out the anatomy of each artery, as you can see it on this slide, and we could successfully do a splenectomy with a complete resection of the mass, as you see it here. So these are cystic incidentalomas, which again are likely to be neoplastic. They could be of various types: serous, mucinous, and IPMNs. And again, I mean, this is a completely separate topic, but a CT scan and an MRI can actually differentiate and distinguish these lesions very well. This is a rough classification that we use. And when you see almost out of 100 patients, only 30 cysts are likely to be pseudocysts. The rest will be some kind of a cystic neoplasm, which needs to be very clearly defined. And this is again where MRCP and a CT scan has a pivotal role to play. So I would just jump this. These are some of the characteristics for cystic lesions of the pancreas. You need to do an endoscopic sampling of the cyst. And I think I'll just, in interest of time, skip the section on neuroendocrine tumors. Again, CT scans and DOTA scans help us in identifying neuroendocrine tumors. The treatment is essentially surgical, and you basically try to take out the tumor. Where it is not possible, you look at alternative treatments, which are somatostatin based or peptide based radionuclide imaging, which helps you to identify this. I think we are beyond time and I would not like to delay everybody. So I think we'll stop it at this point.
Thanks, Swamil. Dr. Jitesh, you can take over on this one.
Yeah.
Thank you. Thank you.
Thank you so much, Dr. Swamil. Now there is a question from the audience.
Yeah.
Now DPP41 and GLPA causes pancreatitis and carcinoma.
I think these are anti-diabetic drugs, and to the best of my knowledge, I mean, I will have to read up the literature, but I don't think these medications are responsible for pancreatitis and cancer. They are very commonly used, and we don't see patients with these medications developing these conditions. So, yeah.
What is the role of surgery in CA head of pancreas?
I think we've answered that. It remains the cornerstone. You need to do a good operation to take the tumor out.
What is the probability of malignancy of pancreas in diabetic patients where already the patient pancreas is transplanted?
No. I mean, if the patient has had a pancreas transplant, generally they have it not for diabetes, but they have it when they have end-stage kidney disease from diabetes. So actually they get a pancreas and kidney transplant together. In our country, at least, isolated pancreas transplant for diabetes is not there, simply because kidney transplants are more common and kidney patients need a pancreas more. So that one thing is that if you develop a cancer, you're more likely to lose control of diabetes, but by itself, diabetes is not a risk factor for development of pancreatic cancer.
Any incidence of post-COVID pancreatitis?
Yes. Yeah. There is some more and more data coming out, but I think nobody really understands this. You're seeing patients with COVID and pancreatitis. It's a correlation rather than the association cannot be defined. I don't think anybody understands COVID also completely. So we should, yeah.
Thank you very much, all the speakers. And I shall now request Dr. Kajal Ahuja,
Assistant Secretary, IMSCGP,
to propose a vote of thanks.
Yeah.
Thank you very much.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Somil Vyas, Dr. Shivsam Jalkote, Dr. Swarup Nellore, and Dr. Karthik Ganesan. I also thank our knowledge partner for the day, Sir H.N. Reliance Hospital. I thank Mr. Deepen Mehta, Mr. Siddharth Linge, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handed all the technical details at the same time. I thank Dr. Anil Awad, President-elect, for conducting this webinar smoothly and efficiently. A big thank you to past President, Dr. Sudhir Patil, for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you.
Thank you, everybody. All
Thank
the
you very
best,
much.
doctors.
Thank you. Thank you.
Okay, bye.
Thank you.
Bye.
Thank you so much.